Audio check. Test 1, 2, 3, 4, 5, 6. 6, 4, 3, 2. Test 1, 2, 3, 4, 5. Audio check.
The committee will come to order. Good morning. I want to welcome everyone here and also extend a special welcome to our guests, Donald Berwick, the administrator at the Centers for Medicare and Medicaid Services, and Richard Foster, Chief Actuary for the Centers for Medicare and Medicaid Services. Dr. Berwick, despite 3 separate requests from the Republicans on the committee to our Democrat counterparts in the last Congress, this is the first time you've actually been invited and appeared before this committee, or any House committee for that matter. So we've been especially looking forward to having you here for what I hope will be an informative and spirited discussion about the impact the Democrats' new health care law will have on Medicare, our seniors, and other beneficiaries who depend on the program to meet their health care needs. I would note that the spending that runs through your agency is greater than what is spent by the Department of Defense. So not only do we have a constitutional responsibility to conduct this oversight, we have a clear fiscal responsibility to the American people given the amount of tax dollars that you control. And if I were going to pick a subtitle for this hearing, I might well borrow a line from Charles Dickens. It was the best of times, it was the worst of times. Because to be honest, as I read through the testimony of our 2 witnesses, and look back through the information we've seen from CMS, I see two very contrasting perspectives appearing from the same agency. On the one hand, we have Dr. Berwick, who has repeatedly touted the benefits of the health care law. In testimony before the Senate Finance Committee last November, Dr. Berwick stated that, and I quote, "Medicare's long-term sustainability is stronger than ever as a result of the new efficiencies, new tools, and resources to reduce waste and fraud and slow growth in Medicare costs," end quote. On the other side, you have Mr. Foster and his team in the CMS Office of the Actuary, who has a 180-degree perspective on the new health care law. In report after report, the Office of the Actuary has provided a bleak outlook about the future of Medicare resulting from the new health care law. This is due in large part to the fact there are more than $1.5 million in cuts to Medicare that have been made in an effort to finance the law. Those changes include massive cuts to hospitals, cuts to home health agencies, cuts to skilled nursing facilities, and cuts to hospice providers. The concern of many on the committee is the impact of this law and the potential to either lose access to health care services or be forced to pay more for the services they need. And sadly, that's already happening, from those who depend on local hospitals to folks who depend on Medicare Advantage plans to retirees receiving retiree drug coverage to seniors who will pay higher prices. And for example, the Medicare actuaries predict that because of the cuts in the Democrats' health care law, 725 hospitals, 2,352 nursing homes, and 1,587 home health agencies will become unprofitable. It's no wonder they warn that seniors' access to care could be jeopardized. 3 Pennsylvania hospitals have been put up for sale, and drastic changes in the new health care law were cited as a factor in that decision. CBO has predicted that beneficiaries who remain in a Medicare Advantage plan will see their annual out-of-pocket costs increase by an average of $816 by 2019. The Medicare trustees predict that 5.8 million seniors will lose their current retiree drug plan provided by their former employer because of the Democrats' health care law, and another 1.7 million seniors who would have otherwise received an offer of retiree prescription drug coverage in the future will no longer have this option. And finally, despite the claims the Medicare donut hole changes will solve the costs facing seniors, the reality is that CBO has predicted that Part D premiums will increase by 4% this year and 9% for all seniors by 2019 as a result of the Democrats' health care law. These are just a few concerns, and I'm sure there are more concerns that will be identified today, including the very fuzzy Washington math that has led some to characterize the financing of the law as a Ponzi scheme. Given the impact the new health care law will have on Medicare and the nation's seniors, it's my hope that in today's hearing we can have an honest and open airing about how CMS plans to institute these cuts while still meeting the long-term needs of our nation's seniors and Medicare beneficiaries. And I now yield to Ranking Member Levin to make an opening statement.
Thank you, Mr. Chairman, and we welcome our 2 witnesses, and I think this will be an opportunity to shatter many of the myths that have been spread about health care reform. For more than 45 years, Medicare has offered important health benefits for senior citizens and people with disabilities, and has safeguarded financial stability for them and their families. The Affordable Care Act builds on the program's strengths, I emphasize that, by investing in Medicare's future, improving benefits, reducing costs for beneficiaries, and getting a better deal for taxpayers. During the health reform debate and in the time since its enactment, health reform opponents have relied on myths and scare tactics to create fear and uncertainty among Medicare beneficiaries. What is really most scary is the plan from Republicans to privatize Medicare through a voucher system. So let's set the record straight, and we'll have more of that today, on health care reform and its impact on Medicare. The Act strengthens Medicare's future, improves benefits for senior citizens and people with disabilities, and saves money for taxpayers. Fact 1, the Act lowers costs to Medicare beneficiaries and improves benefits. Thanks to Medicare payment reforms and efforts to eliminate waste and fraud, beneficiaries will save on average almost $200 on their Part B premiums by 2019. and cost sharing also will go down by more than $200. Fixing the donut hole created by the Republican plan was a key improvement of the Act. We offered immediate assistance with drug costs by providing $250 to over 3 million people. This year, seniors who hit the donut hole will save an average of $500. By 2020, the donut hole will close completely. Finally, seniors will reap benefits due to this elimination of cost sharing for most preventive services and the creation of a new annual physical benefit. Fact 2, the Act significantly strengthens Medicare's financial footing. The Act extends solvency of the trust fund by 12 years. Fact 3, the Act modernizes the Medicare program. It contains an array of delivery reform systems to ensure that the program rewards value over volume. In fact, healthcare experts, including more than 270 leading economists, agree that the Act creates a more disciplined and effective healthcare system. Fact 4, the Act includes tough new fraud-fighting tools that are projected to save taxpayers approximately $5 billion. The law empowers CMS to stop fraud before it happens. But there's one more point that needs to be stressed, and it's the Republican agenda to repeal reform. The repeal agenda would reverse the progress we have made. It would raise beneficiary costs and substantially shorten Medicare solvency. It would end delivery innovations and stop important new fraud-fighting powers in their tracks. My Republican colleagues focus on repealing health care reform and privatizing it by turning it into a voucher system. The repeal agenda shifts medical expenses back onto seniors and their families. When we passed Medicare, it was to fix these very problems, to ensure that seniors would no longer have to spend their retirement in poverty or in fear of the next illness. Repeal would do more than turn back the clock. It would rip off its hands. That is a fact we cannot ignore and a possibility we will not accept.
Well, thank you. Dr. Donald Berwick is the administrator for the Centers for Medicare and Medicaid Services. As administrator, Dr. Berwick oversees the Medicare, Medicaid, and Children's Health Insurance Program. Together, these programs provide care to nearly 1 in 3 Americans. Before assuming leadership of CMS, Dr. Berwick was president and chief executive officer of the Institute for Healthcare Improvement, clinical professor of pediatrics and healthcare policy at the Harvard Medical School, and professor of health policy and management at the Harvard School of Public Health. He is also a pediatrician, adjunct staff in the Department of Medicine at Boston's Children's Hospital, and a consultant in pediatrics at Massachusetts General Hospital. Dr. Berwick, your full written statement will be made part of the record. You have 5 minutes to address the committee, whereupon then members will question you for 5 minutes each. So, Dr. Berwick, welcome to the committee, and you have 5 minutes.
Thank you, Mr. Chairman. I appreciate the chance to appear here. It's a privilege and an honor to serve as the administrator and also to get a chance to be in dialogue with you now and in the future. I am a physician. I'm a pediatrician. I'm the son of a physician, and I'm the father of a newly minted physician. Almost 3/4 of a century span the time between when my father first hung out a shingle in a small town in Connecticut where I grew up, and when my daughter, Jessica, showed up last year for her first day as a primary care resident. My own career is sort of a bridge also between them, from the typewriters that my father used to the computers that Jessica uses, from ignorance about how genes worked to the decoding of the human genome, from helplessness in the face of almost all cancers to cures for many cancers, from the time before Medicare when seniors lived in fear of medical bankruptcy to now when they do not. The Affordable Care Act's a bridge too. It is our nation's answer to many of the problems that modern healthcare brings along with its successes. It's our answers to the questions about healthcare coverage. Will we make sure that our neighbors don't need to be afraid that they're going to lose health insurance when they get sick or not be able to get it in the first place? The answer is yes. People with pre-existing conditions will be able to get insurance, and insurance companies will not be allowed to withdraw coverage from those who become ill. Yes, children under 26 can be covered under their parents' insurance policies. Will Medicare beneficiaries get the drugs that they need at the prices they can afford? The answer is yes now. We've sent over 3 million tax-free rebate checks to seniors to get them through the donut hole. We have discounts now for 50% for covered prescription drugs for people in the donut hole. By 2020, we'll close the donut hole completely. Will we invest in prevention for seniors, not just treat them for the heart attacks and strokes and cancers they could have avoided? The answer is yes. We will add annual wellness checks and cost-free screening tests like mammography and colonoscopy to Medicare benefits. In some ways, though, the biggest question of all, I know, is one that concerns you, which is, can we afford to do that? Is getting the care that we want and that we need, care for everybody, sustainable? The answer to that also is yes. Not only does the Affordable Care Act make Medicare fiscally stronger, it also provides us with the tools to make health care better. And as in the most of the rest of what we do, doing things right is less costly than doing things wrong. Can we afford to meet the needs of patients and families? Yes. We cannot afford not to. When a patient gets an avoidable surgical infection, or when two different doctors who don't have a way to coordinate their care mistakenly prescribe 2 drugs for Mr. Green that ought not to be taken together, the patient, the family, and society all bear the higher costs of the complications. When Mrs. Miller stops taking her medicines because she can't afford them, she will suffer the stroke that will become her greater burden and ours. The diabetes that we fail to prevent or to detect early will become the heart attack or the amputation or the kidney failure that will cost far more in suffering and in dollars to treat later. It is a terrible mistake, in my opinion, to think that the route to affordable health care is to deny people insurance, care, and treatment. That is a very bad plan. Instead, the proactive, patient-centered investments that the Affordable Care Act and Medicare and Medicaid themselves represent are our nation's best hope for the sustainable, excellent health care to which we aspire. Better care, better health, and lower costs through improvement of care, they come together. They're a package deal. Let me focus on one particular case, the Medicare Advantage program, which I know you have concerns about. You're concerned about the strength of the program. We actually have some quite exciting new data just now on enrollments and premiums. Despite earlier projections of enrollment declines and premium increases, the actual data we now have on 2011 shows that enrollment in Medicare Advantage increased 6% to more than 12 million beneficiaries. On average, beneficiaries have seen a 6% reduction in their premiums, and there is a 5% increase in the number of beneficiaries who are now in 4- and 5-star Medicare Advantage contracts this year versus last year. That translates into more beneficiaries being in lower cost and higher quality plans. Higher quality care is what I want for all patients. When I practiced pediatrics, I did everything I possibly could to make sure that my patients had the best medical care possible. I fought for a bone marrow transplant for a young boy for whom that was the last possible chance of success. He got the transplant and he lived. I made sure that kids with asthma got the most modern treatment we had and that their mothers and their fathers and their school teachers understood how to help them. I made sure that immunizations were up to date, that obese kids knew that they had options, because you can never underestimate the value of prevention. And now at CMS, I get to do the same for Medicare and Medicaid and CHIP beneficiaries and for the millions more who will benefit from a healthier private insurance market. It's the same plan. Quality pays. If you want to thrive, don't run away from a problem. Do things right. Better care, better health, and lower costs through improvement. That was my father's plan. That's my daughter's plan. And every day at CMS, it's our plan. Thank you.
Thank you, Dr. Berwick. Your time has expired, but your full statement will be made part of the record. Dr. Berwick, is the British healthcare system, the National Health Service, a good model for us to follow here in the United States?
Mr. Chairman, I've seen and worked in many countries. Every country finds its own solution to its own problems. America needs an American solution to the American healthcare problem, and the Affordable Care Act is certainly that, or the beginning of that. It's a system that balances public and private payment. It depends heavily on the private healthcare sector. It's a good partnership between the federal government and states. It's the American way to an American healthcare system that's sustainable.
Well, regarding the British National Health Service, you made a statement, and that's a service that's notoriously known for rationing care. You said, and I quote, "I fell in love with the NHS. To an American observer, the NHS is such a seductress." Are you still in love with the NHS? Is this still a view you subscribe to?
There are strengths and weaknesses for every healthcare system around the world. We have a lot to learn from each other. But I say again, the American healthcare system needs an American solution, and that's what excites me about the Affordable Care Act. It puts a stake in the ground about the kind of system we can have based on the heritage of our system, the assets we have, our investment in our own public trust, and this extraordinary partnership between public and private care. We're on the route to a solution that fits our country, and that's what really counts.
Would that be a yes or a no?
I am saying that every country finds its own solution. There are strengths in the British healthcare system. There are strengths in every healthcare system I've seen, and enormous weaknesses in all of them. We're all struggling with the same issues.
Well, you also wrote, and I'm quoting here, I admit to my own devotion to a single payer mechanism is the only sensible approach to healthcare finance I can think of. Do you still feel that a government-run single-payer healthcare system is the only sensible approach?
I'm really excited by the promise that the Affordable Care Act offers, Mr. Chairman, to American healthcare. I think we found our way to a really open door here now to a solution of the American healthcare problem. It's an investment in better care, better health, and lower costs for the improvement of care. And as I understand that law more and more, I see more and more tools that our country now has to make care exactly what it should be for every single person here.
Is that a yes or a no to my question?
I'm saying that
I'm having trouble understanding whether you still believe that the single-payer system is the only sensible approach.
I think the Affordable Care Act is a sensible approach for America, and we're seeing progress already. I think we'll see immense progress if we stick with this law. I could see the potential for helping our country actually use innovation and improvement of quality of care, transparency, putting control in the hands of patients. We're going to find our way to a better healthcare system, and this is an exciting opportunity.
If I could have a simple yes or no answer, you said one time that competition, in short, will hurt you, not help you. And now that you'll be in charge of setting up exchanges, determining what health benefit plans will look like, analyzing premiums, do you still feel that competition in healthcare is a bad thing? And I think we need some clarity from you. Is this a yes or a no?
Competition certainly has a place in our healthcare system. It's the American way to excellence in many forms. There are other areas in which providing public support to people through a publicly financed system helps too. It's not a simple yes or no answer to your question, Mr. Chairman. And I think the Affordable Care Act strikes a superb balance between public and private sector investment in better care.
You've also said that any health care funding plan that is just, equitable, civilized, and humane must redistribute wealth from the richer among us to the poor and less fortunate. Is this a view you still subscribe to?
Statement of fact, Mr. Chairman, sick people tend to be poorer and poor people tend to be sicker. And if we're investing in the health of our neighbors and our nation, we're going to have to take care of the sicker and poorer in our country. And we've done that. That's why Medicare and Medicaid are there in the first place.
And you think wealth redistribution is the way to go about achieving that goal?
Poorer people tend to be sicker and sicker people tend to be poor. And if we really want to help each other, we're going to have to understand that and address it. And we have in our public policy. That's where Medicaid came from in the first place, Mr. Chairman.
We've heard that this legislation will mean that most preventative care will now be free because of this new health care law. And you once wrote that one over-demanded service is prevention, annual physicals, screening tests, and other measures that supposedly help catch diseases early. Do you still feel that preventative care is in too high of a demand?
Mr. Chairman, I'm a pediatrician. I spent my life in preventive services. The whole idea in taking care of children is to give them effective prevention so they don't get the diseases that will later pay the price for. There is effective prevention and ineffective prevention. The Affordable Care Act is a tremendous investment in getting people effective preventive services. That's why they cover mammography and colonoscopy now at no co-payment for the patient. That's why we introduced the annual wellness physical. Effective prevention is the best investment we can make in both higher quality, better life, and lower costs.
So I would take it that's a no then. I would take it that you do not feel that preventative care is in too high of a demand.
Sorry, Mr. Chairman, I don't understand.
The question I asked you was, after reading your quote,
Yes.
do you still feel that preventative care is in too high demand?
Is in
And I
too
guess from
high
your
demand.
answer, you do not feel that preventative care is in too high demand.
I must say, Mr. Chairman, I don't recognize your quote. I'm telling you what I think, which is that effective prevention is a
You
tremendous
wrote it
investment.
once. It was in your writings. I'm quoting your writings, and it was, I'm reading it from We Can Cut Costs and Improve Care at the Same Time by Donald Berwick, Medical Economics, August 12, 1996, page 186.
I believe we can cut costs and improve care at the same time by investing in effective care, and that certainly includes investing in effective preventive services, which is what the Affordable Care Act at last allows us to do for seniors who now can be protected from strokes and heart attacks and complications of diabetes as never before.
So the answer is no. You don't feel that preventative care is in too high demand.
Is in too high demand.
That's what I'm asking.
I believe that offering effective preventive services is a terrific investment for our nation, and that's what the Affordable Care Act does.
All right. Mr. Levin may inquire.
Yes, I was going to say, I think it's important everybody hear your answers.
Thank you.
And so the mic will be clear, and I'm glad that the chairman asked you these questions so that the air can be cleared when it's often, I think, misrepresented, and so we can move on and you can provide the services that you have been trained to prepare, to provide. So I'm glad those questions were asked. I don't think you were surprised. Let me just ask you in terms of separating fact from myth. Mr. Camp, in his opening statement, talked about more than $1/2 trillion in cuts to Medicare. Would you comment on that?
We have an unsustainable healthcare system now. That's the problem we're struggling with no matter which side of the aisle you're on. We have a system that our country is having trouble affording, and it's failing to meet the needs of many of its citizens, and we're trying to navigate our way to a solution. I think the Affordable Care Act offers an opportunity to offer every American better care, not just those in Medicare and Medicaid, but everyone, a better system, safer, more effective, more patient-centered. There are investments in innovation. There are investments in continuity of care so that patients with chronic illness who need to be handed off well from hospital to home or from doctor to doctor can get that kind of support. These all improve the quality of care. And through that, we're going to see costs fall over time. The Affordable Care Act has many potential elements in it that will, I think, in the long run result in savings for our country and for beneficiaries themselves.
So when there's a reference to $1/2 trillion cuts in Medicare, these so-called cuts relate in most cases to the rate of increase in reimbursements and payments to providers. Isn't that true?
We're on an unsustainable trajectory, and we need to find a way to lower costs. The Affordable Care Act is linking reimbursement to providers more and more to the quality of what they do. Instead of paying for care in fragments or pieces or high-volume care alone, we're orienting more and more of payment in this country, on the public and private side both, to paying providers for excellence, for producing the care that we want and we need. An example would be infections in hospitals. There are hospitals all over this country that now have reduced many forms of infection to zero. I've visited those hospitals. I've seen them. The question now is, if it can be done there, can it be done everywhere? The answer is yes, if we invest in it. The Affordable Care Act invests in innovations that will allow things like infection control to be spread all over the country now. Every single hospital offering excellence at the level that the best currently do. That lowers costs and improves quality at the same time. And that's a plan that will get us to a more sustainable healthcare system, and in the end, a more sustainable Medicare trust fund, Medicaid system, and healthcare as a whole.
Do you want to comment on this claim that 5.8 million seniors will lose their current retiree drug plan provided by the former employer, also in the statement of our chairman?
We're in a transitional mode in American healthcare. The Affordable Care Act helps the retiree drug programs with the retiree drug subsidy. Businesses will make their decisions about continuing or not continuing their retiree drug plans, and the beneficiaries will choose among the things available to them, and I'm sure there will be some shifts. You know, the Part D program, the alternative to the retiree drug program in many cases, has been strengthened immensely over the past year or two now. We have strong evidence of much better supply in the Part D program, and we now have we have the 50% drug discount for brand name drugs, so that some retiree drug beneficiaries will choose to move over to Part D because it's a better plan for them.
Thank you.
Thank you. The chairman of the Health Subcommittee, Mr. Herger, may inquire.
Thank you, Mr. Chairman, and Dr. Berwick. I want to thank you for being here this morning. I appreciate your dedication to creating a high-quality healthcare system, but I think we have some very fundamental disagreements about how to achieve that goal. Chairman Camp highlighted your past support for a single-payer system and your comment that, quote, competition, in short, will hurt you, not help you, close quote. Dr. Berwick, do you believe competition and market forces are good or bad for healthcare in light of your quote?
On the whole, good, Congressman Herger. We can see that in the durable medical equipment bidding system, for example, in which we're using market forces to enhance the benefits to beneficiaries, reduce their costs of durable medical equipment, at the same time assuring a supply of excellent DME. That program alone has reduced the spend for the 9 areas that the DME program was tried in by 32%, extrapolating to the country as a whole. That would be a saving over the next 10 years of $27 or $28 billion, of which $17 billion gets returned to the trust fund and $11 billion to beneficiaries. That's constructive use of competition in a very important arena, increasing excellence, increasing transparency, decreasing costs, and increasing the well-being of the people who use those products and services.
Well, thank you. So, in other words, you don't agree with your statement where you said competition, in short, will hurt you, not help you?
There are instances where competition is very helpful, and I've just cited one. There are instances where it's probably less useful, but in this particular, in a rural setting where there's only a single hospital, a critical access hospital, and that's the only supply in town, we can't use competition as the major lever for improvement in that. We have to reach out and help that setting and make sure that it can supply the goods, the services and excellence that that community needs. Sometimes it helps, sometimes it doesn't. But the answer to your question before is, do I think competition can help? The answer is yes, in many cases, absolutely.
Which is directly opposite of what your quote was. But the reason that I and many others find your past statements troubling is because America was built on the free enterprise system. Going back to our founding fathers, Americans have always believed that free people working in free markets make better decisions than any king or dictator or government bureaucrat could ever make for them. And that's what this health care debate is fundamentally about. Are we going to stick with the free enterprise system that has brought about the greatest prosperity in the history of the world, or are we going to hand over the keys to the government? Will we trust patients owns doctors to determine the best course of medical treatment, or will we leave that decision up to a district bureaucrat who has never met the patient? You are now overseeing an agency that provides health care benefits to more than 11 million beneficiaries in Medicare Advantage and 19 million in Medicare prescription drug plans. Congress designed Medicare Advantage and Medicare Part D to give senior citizens a choice of plans so they can pick the plan that works best for them instead of being forced into a one-size-fits-all government plan. Given your repeated statements expressing skepticism about the private health care market and competition, how will you reconcile your personal beliefs with your responsibility to administer these programs that are built on the principles of competition and consumer choice?
Congressman, I can't think of a better example of American-style competition benefiting everyone than, say, with the evolution right now of the Medicare Part C program, the Medicare Advantage program. Look at what's happening. More transparency, more negotiation, more visible understanding by beneficiaries of the quality of the plans they can choose from, an open market in the Medicare NU handbook and on the web where they can search for the plan that they want, and then they buy it, and what happens? Quality goes up and costs go down. That's the free market at work with the support of Medicare to make this a transparent environment in which the beneficiary can make choices. We're interested in more choice, not less, and it's working.
And I couldn't agree with you more, but I hope you recognize that what you've just said and your statements and answers to Chairman Camp are very different than these quotes that you've made in the past. But thank you very much.
Thank you. The gentleman's time has expired. Mr. Johnson is recognized.
Thank you, Mr. Chairman, Doctor. You know, the administration and Democrats here in Congress made promises to seniors about their health care and unfortunately didn't live up to them. In many cases, the law's provisions are going to harm, not help Americans, primarily by raising premiums and reducing access. I mean, the Medicare actuaries warn that the $1.5 trillion in Medicare cuts in the Democrat health care law are so drastic that providers might end their participation in the program, probably jeopardizing access to care for beneficiaries. And you know as well as I do, there are docs that are getting out of Medicare now because they can't deal with it. And I don't know if you have a private office or not, but most of the docs I know have to hire 2 or 3 extra people just to track the administrivia that goes along with that Medicare junk. The Congressional Budget Office also expressed concern that it's unclear if the law's Medicare cuts can be sustained and whether the slower rate of growth will be accomplished through greater efficiency or instead reduce access to care or diminish the quality of care for Medicare beneficiaries. You know, in Texas, more than 300 doctors have dropped the Medicare program in the last 2 years. And you're aware of that, I'm sure, including 50 in the first 3 months of 2010. Some docs feel the only way they can have control over their practice is to stop taking Medicare patients. Of course, not all docs drop out of the program. Some doctors are choosing to increase fees, reduce staff wages and benefits, and reduce charity care. Those alternatives don't sound good to me. As a CMS administrator, how do you plan to prevent seniors from being denied access to care as a result of the massive Medicare cuts in the program?
It's tough times for all. Everyone is tightening their belt in this economy. I know that, but let me say that I've never been more optimistic about the future of the healthcare system in our country with the Affordable Care Act in our hands. I'm told now that the participation in the Medicare system is the highest this year than it has ever been in history among physicians. We're getting the support. The Affordable Care Act was supported by the American Medical Association, the American Hospital Association, professional societies, and trade associations. I don't think they'd be supporting an act that they think spells doom for them.
Well, how do you
Everyone
account
knows
for
we're
300 doctors dropping it in Texas?
Not everyone agrees with the Affordable Care Act, of course, but the associations whose job is to make sure that the well-being of their part of the industry proceeds well are supporting this act. They know that the future lies in better care, better health, and lower cost, and I think they're interested in engaging with us on the public and private side both, in making health care better. That's what they say to me when they meet with me. I've been going all over the country, meeting with hospital leaders and professional leaders, and I think everybody that I'm speaking with knows we've got to navigate our way to a better healthcare system together in public and private partnership. And I think we're headed in that direction.
You know, I don't know how you plan to prevent seniors from being denied access. What kind of steps are you going to put in place so you can identify the problem before it becomes a crisis?
More transparency, more knowledge about what's going on, more linkage of quality to payment instead of paying.
And how do you do that if the docs refuse to be part of Medicare anymore?
96% of the docs are participating in Medicare, and they're more than willing to work with us, and the ones I've met with, and they know that in the long run, better care is the answer for them, for the patients, for the sustainability of the country, and we're going to work hard with the providers of care all over this country to make that care better. They know in the long run that that's how they'll do the best for their patients, and that's what counts. The hospitals want to be safer, they want to be higher quality, and we'll work with them to get them in that direction. In the end, an extra readmission that shouldn't have happened because we dropped the ball helps no one. Hospitals know that, doctors know that, and we're going to work for better care. And that will be why people came into healthcare in the first place and why they want to stay there.
Well, I don't know how you're going to get to the docs that quit the system because they can't stand it. Thank you, Mr. Chairman.
Thank you. Mr. Rangel is recognized.
Thank you so much, Mr. Chairman. And Doctor, thank you so much for sharing with us the knowledge that you have so that our government can do a better job, which you and your family have dedicated your life to. I just want to correct the record because the chairman had indicated in his opening statement that 3 Catholic universities in Pennsylvania were closed because of the Affordable Care Act, and they rushed to make certain that some of us knew that the Affordable Care Act had nothing to do at all with the sale, and that they had promised to, or had indicated that they wanted to do this long before the act. And the president is a Roman Catholic nun, and she is the one that wanted to clarify the record and her support for the act. Having said that, it just amazes me as to the opposition to this revolutionary concept of broad national coverage. What's your guesstimate of the number of Americans that have health insurance coverage?
The number that have health insurance coverage?
That have health coverage of some kind?
I don't know the exact number. I know that we've closed the gap a lot with the Affordable Care Act. When that
I heard
act
it's
is
about
fully-
30% who don't have coverage.
As the Affordable Care Act gets into play, we're going to be closing that by over 30 million Americans that will have coverage they otherwise
Now,
wouldn't
these
have.
people somehow manage to get health care even though they're not covered by insurance. Is that true?
That's true.
And normally, not normally, but many of them go to emergency clinics in order to get this health care. And it's my understanding that this is a very expensive way to get health care treatment.
You're absolutely right, Congressman. It's you pay me now, you pay me later. When the patient comes in and you detect their diabetes early, they don't get kidney failure later. If they don't have access to care, the complications will occur, and they will show up later in the emergency room or the safety net system, and they'll be expensive in a different way right out of our public treasury often.
And when I was a kid, things were that you never went to see a doctor unless you were sick. But now I think it's abundantly clear that you can prevent so many serious illnesses, as you said in your testimony, by being able to go without having enormous costs to prevent these things from happening.
Absolutely right. We know, or the Director of Centers for Disease Control, Dr. Frieden, has pointed out that with 3 or 4 simple preventive steps, we could reduce hundreds of thousands of heart attacks and strokes and other cardiovascular diseases in our country.
Now, if you already have coverage and you're paying your premiums, are not included in the premiums the costs for the people who don't have coverage?
Eventually, it comes around. Somebody has to pay.
So if those who have premiums can find some way to reduce the costs of those who are not insured, does that not mean that your premiums should be expected to be lowered?
Your premiums can be lowered, and in the long run, the savings will be there because somewhere in the tax system, in wages, and in premiums, that money will be saved and will come back into the American economy instead of being wasted in ill health that we could have avoided.
And so if we could develop a plan where most all people, one way or the other, would be able to get preventive care, would be able to get some type of care to prevent them from being hospitalized or prevent their illnesses from becoming chronic, then everybody not only gets a better quality of care, but the cost per capita is dramatically lower.
Exactly, Congressman.
Now, if that is true, I guess coming from Lenox Avenue in Harlem, New York, that those who have coverage probably take the attitude, I got mine, Jack, it's up to you to get yours, because I think we've done a terrible job, and I want to thank the Republican majority for giving us a second chance of really showing the benefits of the program, because the law is complicated. But if you have a child with a precondition, you can better appreciate it today. If you have a kid that's under 26 and you couldn't get coverage, if you have high costs for prescription drugs, all of these things, the public is beginning to understand what's in the bill. So I would like to take this opportunity to thank the Republican majority for giving us an opportunity not only to defend the bill that this committee majority was so proud of playing a major part in, and giving us an opportunity not just to defend, but to point out that in the short and long run, this is best for our nation, and I appreciate your patience with us. And Mr. Chairman, these hospitals that you referred to have sent out a a release that I would like unanimous consent to be included in the record and saying sale it was, but it had nothing to do with the law that's before the committee.
Without objection, and the gentleman's gratitude to the majority is duly noted. His time has expired, and Mr. Brady is recognized.
I, too, am grateful. Republicans oppose this health care plan because it won't lower prices for Americans. It will drive people out of plans they prefer. We can never hope to afford it. And a lot of companies that provide health care today are going to drop them, none of which we think is the right solution for our health care reform in America. So let's get specific. You know, how many seniors have lost their Medicare Advantage plan since President Obama's plan was put in place?
Congressman, there's always turnover in Medicare Advantage. I don't know the exact number that have changed.
No, these aren't
plans.
turnovers. How many have been forced out of their preferred Medicare Advantage plan? Your agency says 700,000. Are they right?
That's a turnover number. They can choose to be in Medicare Advantage or not. It's a
No,
system in which
no.
people can
You-
choose.
Your actuaries said 700,000 seniors have already been forced out of their preferred Medicare Advantage plan. Is your agency correct?
Medicare Advantage plans are a market system in which beneficiaries can choose, and they choose
Is
to
your
move among.
actuary, their report accurate?
What I know right now, sir, is that enrollment in Medicare Advantage plans is up 6% this year. More
Yeah.
people are exercising their choices, and they have choices.
Is that a little misleading since the cuts on Medicare Advantage haven't taken place yet?
Well, we're seeing heavy marketing by Medicare Advantage plans. There's growth in those plans.
It is.
Reductions in premiums.
If you could send back to us how many seniors have lost their Medicare Advantage plan, been forced out of their preferred plan by state, I would appreciate. How many seniors will lose their preferred Medicare Advantage plan under the President's new National Health Care Plan?
Medicare Advantage options are robust for Medicare Advantage beneficiaries, and they choose the plan that meets their needs.
Your actuaries say 7.4 million. Are your people correct?
We're seeing an increase, sir, in the enrollment in Medicare Advantage, and
Because the cuts haven't taken place.
we're seeing investments by
If you could
Medicare
get me
Advantage plans.
that answer, I'm not trying to interrupt, but since you already have these numbers, it'd be great to refer to them.
We'll be happy to
And they
work
come
with you
from.
afterwards, sir.
How many of those in Part D, our prescription plan for seniors, how many have lost their preferred plan since the President's plan took place?
Sir, the number of sound options, meaningful choices for Medicare beneficiaries in both C and D are increasing, and beneficiaries are taking advantage of those
Your
plans at a higher rate.
agency says 3 million this past year have already been forced out of their plan. Are your actuaries right?
We're seeing turnover in Medicare Part D and C, as we always do.
How
Some
many
plans are
seniors
leaving the market, some-
in the Part D have been automatically enrolled in a preferred or Part D plan that costs them more?
I don't know the answer to that, sir.
Your folks say 1.5 million. Can you provide both for Part D and those forced into a higher cost plan? Can you provide that to us by state?
Happily.
The donut hole, the way that was closed is highly flawed, creates cost shifting within it. For the 90% of seniors who do not reach the donut hole, can you guarantee that they will not see higher premiums as a result of closing the donut hole? For those who are not in it
As a
and
result
not
of-
touched by.
As a result
can you-
of closing
yes.
the donut hole?
Yeah.
Part D premiums rose slightly this year from, I think, $29 or $30 on average. I'm not quite sure I understand what you mean, that their premiums will rise as a consequence of closing the donut hole.
Yes, because you're cost shifting within the donut hole. You're taking the 90% who do not reach it and taking the cost of closing it and applying it to them. Your actuaries say their premiums will go up.
Congressman, what I know is that a patient that gets to the donut hole needs their medications to preserve their life and their health and their function, and if they can't afford them, then they get sicker, we end up paying, and their families
So can you
bear the suffering.
guarantee for seniors who are not in the donut hole that their premiums won't go up?
It is so important to provide people medications when they reach that donut hole, and I think that we're seeing much more confidence on the part of seniors that they can get the medications they afford.
Does the Deceptive Trade Practices Act apply to Obamacare?
Does the Deceptive Trade Practices Act apply to Obamacare? Can
I'm
you explain
being
your question?
only halfway facetious.
Yeah.
It seems to me none of the promises made to our seniors under the President's National Health Care Plan will come true. Many are forced out of their plans. We'll see higher premiums. That is why Republicans are serious about coming back with better solutions for seniors.
Congressman, what I have in front of me are the
The
data.
gentleman's time has expired. If you
you.
would like to submit a response in writing, you're certainly welcome to
Happily,
do that.
thank you.
Mr. Teaberry is recognized.
Thank you,
for
Mr.
5
Chairman, for
minutes.
having this hearing today and kind of dovetailing on Chairman Brady's comments about Republicans wanting to have better solutions for seniors. It kind of goes along with my line of questioning. It was disappointing to hear the ranking member express concern in the rhetorical fashion that he did with respect to this hearing and what Republicans believe and why Republicans voted to repeal this bill is because we do care about the impact of this bill to real people. And having $500 billion taken out of this system is a good reason to have this hearing today and get information from Dr. Berwick and Mr. Foster and continuing a discussion, because Dr. Berwick, thank you for doing what you're doing and being here today, but we represent a lot of people in a lot of different parts of this country. And in my district in Central Ohio, and Mr. Levin's been to my district, not on my behalf, but he's been to my district, there are doctors, there are seniors, there are hospital administrators. There's the largest, Dr. Berwick, the largest Medicare Advantage provider in my district is a nonprofit Catholic hospital. And they're all very, very concerned about the impact that this bill, this law has with seniors. Not insurance companies, not wealthy seniors. I'm talking about real people. My dad has a 6th grade education. My mom has an 8th grade education. They're on Medicare. My physician, Dr. Randy, I'll call him, a primary care physician, his father-in-law lost his primary care physician because he no longer was going to take Medicare patients. So my physician, Dr. Randy, said, Dad, I'll find you a doc. I know a lot of doctors out there. Columbus, Ohio is the 15th largest city in America. This doctor friend of mine could not find a doctor for his dad, his father-in-law, because nobody would take new Medicare patients based upon the new law. So he is now taking his father-in-law as a new patient, which he said he would never do. A lady in my district, Joni, came to me teary-eyed because her mother, a Medicare patient, first lost her Medicare Advantage program, so had to go into Medicare fee-for-service. And I just give you this as examples. And then lost her doctor, who said, I am done with Medicare. We have a large city. We have 4 healthy hospitals, 3 of which are very concerned about the new law. We have a doctors association, unlike the American Medical Association, the Ohio State Medical Association, who oppose the bill, who support repeal. They want reform, don't get me wrong, they want reform, but they're very concerned about what this legislation does. And so I understand what the minority has said. I appreciate your testimony, but the reality on the ground that I see as a son of seniors, as someone who wants to improve our healthcare system, who wants better access, who wants lower cost, who really wants people to keep what they have, which was one of the president's goals, a wonderful goal, by the way, Dr. Berwick. I thought the president was spot on that. But the reality on the ground, at least in Central Ohio, is people aren't being able to keep what they have. Seniors are frightened that they're losing coverage in reality that they had and they liked, that they chose. Seniors are frightened that they're losing doctors. My mom lost her doctor. And when you're 70 years old and you've had a doctor for a long time, you build a really good relationship with that doctor, you're frightened to face a situation where now you have to go on to another doctor that you don't know who that's going to be, But you're talking to other seniors. My mom and dad walk every morning at a local mall with, like, it's a seniors club. And we know what they're talking about. Are there going to be any doctors left that take senior citizens? And this is a year after this bill went into effect. And Dr. Berwick, you're a physician. These physicians talk to their patients, and they express concern about the new health care bill, many of whom supported it when it first was talked about, but opposed it in the end. So my question to you is, let's not talk about the statistics. Let's talk about what I say, what you say, what the chairman says to constituents who on the ground are seeing a reality that's much different than the rhetoric of when this bill passed and what the goals were. People are losing the coverage they had, and they're losing their doctors, and their doctors are blaming the bill.
And your question,
If you want to respond briefly, the gentleman's time just expired. I'll give you a few seconds to answer, and then you can supplement it in writing.
I will do that, Mr. Chairman. I'm meeting all the time, Congressman, with doctors, and I have the same objective you do. We need a robust medical profession, a strong support to that profession, and we're committed to that. You and I both are. I'm hearing a different story. The physicians I meet with want to participate in the change of health care that the Affordable Care Act offers. They're actively engaging in issues related to changing the form of care to make it sustainable, better for them and for their patients, and I think we can get there. And apparently, unlike you, I think the Affordable Care Act provides us a very strong foundation for that progress for the professions as well as for the beneficiaries.
All right. Thank you.
Thank
Mr.
you.
Stark is recognized.
Thank you, Mr. Chairman. Thank you for holding this hearing, and thank you for being here to enlighten us. The Affordable Care Act has a variety of initiatives to modernize the Medicare program and make sure that we're, I hope, recognizing value more than volume. What has as you move among the provider community across the country, what is the reaction you're hearing?
To the modernization of healthcare, it's
Yes.
excitement everywhere. We're seeing it first in some of the information technology work that's going on now. We finally are at the threshold of really modernizing information technology for the providers of care and the beneficiaries of care in this country. It's going to make a tremendous difference. Beyond that, physicians today can be very frustrated by the fragmentation in the healthcare system. People move from place to place and get dropped. The Affordable Care Act has in it the opportunity now to reward and support continuous, seamless care. So the patient with diabetes that's seeing 3 or 4 different doctors knows that her journey is being crafted, will be able to build accountable care organizations, move payment toward bundled payment, link payment to quality of care for both health plans and hospitals so that continuity gets established. Doctors all over this country and providers of care are quite excited about this progress into a better care system. And Congress, in its wisdom, has given us these gifts of the Innovation Center in the Affordable Care Act and the Federal Coordinated Healthcare Office for dual eligibles. I can't tell you how important these are. The Innovation Center is going to liberate all of the imagination around the country, place by place, community by community, to find better ways to deliver care. And when a hospital in Nebraska or Maine develops a better way to make patients safer or to take better care of someone with multiple sclerosis, we can learn about that and spread that news all over the country. We're on the threshold of a tremendous boost in innovation, creativity, and spread of better care around this country. And the doctors know that. That's what they're talking with me about.
And would it be your understanding that, I guess this isn't a yes or no, but that there is a positive role for government to play in the delivery of medical care in this country, and that could be led by the members of Congress if they decided that to work together and do it?
We're already doing it. I mean, it's a catalytic role. You set the stage for the healthcare system to do what it wants to do, for doctors to thrive and commit themselves to patients. You do that as you provide the resources to help them make care more continuous, safer, to invest in prevention like the Affordable Care Act does. But let's make no mistake about it. Government has no role at all in the encounter between the doctor and the patient, honoring the sanctity of that consulting room is really, really key. I'm totally committed to that. But we set the stage for those two people to meet each other and work together when things are done right. So it's a combination of government support, encouragement, reward, and the competence and the commitment that professionals have when they encounter patients, and the patients have when they are confident in the professional. It's a balance.
Thank you very, very much for what you're doing, and I look forward to, as I know members of our committee do, to working with you over the next couple of years to see that we can improve the system and with your cooperation. Appreciate it very much. Thank you.
Mr. Stark, and thank you for your leadership.
Thank you. Mr. Davis is recognized.
Thank you, Mr. Chairman. Your comment on healthcare being liberated, we have private sector has been innovating for decades and sharing common information among the professions, and I just find it hard to believe to talk about innovation in the context that we have in a variety of issues, from programmatic perspectives to the issue just recently discussed. I didn't go to Harvard. I went to West Point. And the one thing that I would have to say at the beginning of this, listening to this hearing, having watched my mother navigate through the system that was managed by your agency, and we talk about affordability and innovation. In the world where I grew up, both academically and professionally, these answers would be called equivocation. There are straight yes and no answers about cuts on issues, and I think it's very important to share the truth of this and avoid the posturing for the lives that we say that we want to save. Successful physicians that I know are known for their candor as well as their bedside manner and sharing factually what is before people. I have not heard one doctor, save one who is in a very different place politically than the rest of the entire Kentucky Medical Association, whose head I met with yesterday, who's not said this is going to limit their capacity, increase their overhead, increase their cost, and is going to cause a very serious problem for senior citizens. When you talked about the comparative bidding being a good thing, it's not pay me now or pay me later, it's pay me now and pay me later. Directly, I have a long-term BME provider that's well-established in my community, lost their ability to bid. The California company won, and coming on the backside of this, because they had no local capacity to deliver, guess who they turned around to subcontract? Was the company that had been doing the business at a lower cost before. Let's say, counterintuitive answers are not here. And admittedly, I'm not a doctor. One of my opponent's sons played one on television, but I will have to say that I'm most disappointed in the lack of candid answers on these issues, because we want to help you improve this system. It's been made more complicated by the bill. And in my other life, it would be read the problem. If you read the bill, it does not connect the dots by creating 162 new agencies, commissions, and boards. Cutting direct benefits and increasing taxes is not a recipe for improved capacity. I want increased access. And coming to that, many of my constituents are on Medicare Advantage. You know how many people are actually in the program, Dr. Berwick?
About 12 million, I believe.
That's correct. It's about 12 million people. Do you know how many people were in the program in 2005?
I don't, sir.
It was about 5.3 million, less than half of what it is today. So the market working competitively, seniors were moving to this as a preference program of choice. And I think the numbers say something about the popularity, don't you?
Yes, I mean, Medicare Advantage has tremendous opportunities embedded in it, as well as significant problems.
Well, I would say that the customers tend to vote with their feet, no different than the doctors who are pulling out of Medicare in droves. I'm seeing the same thing happening in the Ohio Valley. I'm in the same vicinity as Mr. Teaberry here. We're seeing that happen in the medical professions. It's getting to a point because of this bill. I have a doctor a daughter who wants to go to medical school, has been told by 7 different physicians not to go because of the truncation and the complication in the healthcare system that's going to be placed upon future physicians. But coming back to Medicare Advantage, your own actuary said last year, as Mr. Brady pointed out, that 7.4 million seniors would lose their coverage in Medicare Advantage. Is your actuary correct?
The actuary's making predictions of the future, sir. What I have is the evidence before us today. We have this.
I didn't ask you that question. I asked you, is your actuary correct in his calculations?
The actuary's making a prediction. I can't judge whether he's correct or not. What I can tell you are the facts now, sir.
I'll go back to our academic education. The commander's responsible for what the unit does or fails to do. I'm not interested in an academic salon answer. Is your actuary correct in the assumptions that your department submitted to this committee?
Sir, I'm not commander.
You're the leader of, you lead a budget larger than the Defense Department, sir. Please answer the question.
I lead an agency in which the growth rate in Medicare Advantage this year is 6%, and the actuary predicted a decrease. So the actuary's prediction was incorrect. Our Medicare Advantage is healthier now than it ever was before.
So Medicare Advantage is a good program. Then why would he say that the people are going to be cut out of the program by the very legislation that you're advocating?
What I'm saying is that I have the facts on the ground before me now, and the facts are that Medicare Advantage is looking stronger and stronger. We're seeing plans invest in expansion of Medicare Advantage. We're seeing robust choices for beneficiaries, 26 choices per county on average in this country. Average premiums going down 6%, enrollment going up 6%. That looks like a very robust program. And these are smart businessmen out there. People who run the Medicare Advantage plans are investing in a future that looks pretty bright to them, or I don't think they'd be investing the way we're seeing them invest right now. Medicare Advantage looks healthy.
All right, thank you. The gentleman's time has expired. Mr. Reichert is recognized.
Thank you, Mr. Chairman. Doctor, thank you for being here today. I'm not a doctor either, but I've been a patient many times. So I'm looking at the system as most Americans would from that side of the issue. We had I'm disappointed too, as Mr. Davis has stated in the way that you're answering or not answering some of the questions. So I hope that you understand our frustration here with some of your responses. You know, most Americans are just trying to figure this thing out. They need your help to do that. A lot of people are listening today. This is streamed live, C-SPAN, so there'll be a lot of Americans listening to your words. You obviously support the Affordable Health Care Act. We had a witness in a couple of weeks ago whose name is Austin Goolsbee. Do you know him?
Yes.
The chairman of the Council of Economic Advisory. He said that the health care bill would increase access, decrease costs, increase benefits, reduce the deficit, and people would be allowed to keep their health care if they wanted to. Would you agree with those statements? Does the bill accomplish those things?
It appears to be yes.
Is that a yes?
Yes.
Okay. Is there anything at all in the bill that you would change?
We're going to learn over time. That's a complex question.
But you've had some time to read the bill and look at the bill. Is there anything that stands out in your mind that you would change? What don't you like about the bill, or is it all good?
It's a very complicated bill, sir.
Is there anything about the bill you don't like?
You know, right now I'm implementing the bill.
No, is there, yes or no, I guess, because I'm not going to get a straight answer. Is there anything about the bill that you would change today? Yes, no.
Over time, we're going to learn about this bill, sir, and I can tell you,
from what you know today, from what you know today, sir, is there anything that you would change?
There's in the whole.
Sir, soon. Can you tell me when the $206 billion cuts to Medicare Advantage begin?
Well, right now the payments are stabilized.
When do the $206 billion cuts begin? What's the target date, the set date? What year?
The cuts are phased in over time.
And when do they begin?
It depends on the plan. And
what year do the cuts begin? Can you give me a year?
It's variable depending on the plan and the area. So
2017, $206 billion in cuts will begin to take place. Your actuaries say, as Mr. Davis has asked you, that there would be 7.4 million seniors then leaving that system, losing their health care. So the statement that you agreed with earlier, that Mr. Goolsbee also agreed with, you can keep your health care if you want to, isn't a true statement. Even the President of the United States has said in a public forum, which I was present at, he said there may have been some, in regard to the statement that you can keep your health care plan if you like it, he said there may have been some language snuck into the bill that runs contrary to that premise. Now, if there is language in the bill that runs contrary to this present premise, and according to the president, it does. Would you change that language?
Sir, Medicare Advantage.
Would you change the language? If there's language in the bill, as the president says there is, that got snuck into the bill, would you change the language that prohibits people from keeping the health care they like?
People in Medicare
Would you change the
Advantage-
language, sir, if there's language in the bill? That's a yes or no question.
I
If
can't
there's
answer
language in the bill, yes or no?
I'd love to be able to answer your question, yes or
You-
no. I can't.
If there's language in the bill, sir, why can't you answer the question? It's a simple question. If there's language in the bill that says, as the president has said, that runs contrary to the promise that you can keep your health care if you like it, why would you not say yes to that question, that I will change that language? Because we believe, and we have said over and over again, if you like your health care plan, you can keep it. Why would you not change that
Congressman,
language?
to
sir?
me,
Why would you not change that language, sir? Answer
sir,
the question.
you're asking a hypothetical question, sir. What I can tell you is our job.
No, I'm not, no, sir, I'm not. The President of the United States has made this statement. There's language in the
Mr.
bill.
Chairman, I need to object.
Well,
I
sir,
let me
this
just-
is my, this is my time,
if the-
Mr. Levin.
If the gentleman from Washington State would suspend, Mr. Levin?
I will find a way to object. I think we have to let witnesses answer questions, sir.
I agree.
This is
All
not
right.
a star chamber.
Back to regular order. The gentleman from Washington's time is about to expire, so you have about 2 or 3 seconds left, and then we'll leave a few seconds for Mr. Berwick to answer the question. The gentleman is entitled to an answer to his question.
Mr. Chairman, I would just ask for a straight answer from the witness. Thank you, and I
All right,
yield
Mr.
back.
Berwick, you have a few seconds, as I have done to the minority, to respond to
Mr. Chairman, I'm
question.
not aware of any such language in the bill, and the question to me sounds hypothetical.
All right, thank you. Mr. McDermott is recognized.
Thank you, Mr. Chairman. Dr. Berwick, you've given a bravura performance in political theater. You've been brought to a stage today and put into a play that you really don't want to be in. You want to be doing your job. This is a stage being set to get rid of Medicare. The Republicans have never liked Medicare. When Harry Truman proposed it in 1946, the Republicans started talking of socialized medicine, playing on the fears of what was going on in the Soviet Union. They have used these fear and misinformation tactics then, and they're using them again here today. Now, when Medicare passed in 1965, most Republicans voted no. And what we are really doing here today is trying to poke holes in the bill, but we've been here 100 days, and the committee has laid no proposal on the table to make it better. Everybody is talking about what's wrong with it. Bill Frist said, don't repeal, make it better. So all we have in front of us is one plan that's on the table, Paul Ryan's roadmap. He wants to give a voucher to every senior citizen in this country. Now, let's be serious. The point of that is that the Republicans believe that seniors need to put more skin in the game. And I want to be crystal clear here. Seniors already spend 1/3 of their income on health care. They can't afford any more skin in the game. So whatever I hear here is really about the Paul Ryan plan. And I would like you to take the time here to tell us what you think will happen when they repeal or begin to undercut and destroy this and work toward putting a voucher plan, because that's the only thing they put on the table. And I believe that all the Republicans are for it because none of them have stood up and said, we don't want a voucher system. We want to make this system better. We hate Obamacare. We want to get rid of it and put in the voucher system. So tell us what a voucher system would do to seniors in this country.
It put them at risk. People, they already have skin in their game. Their bodies are in the game. The whole idea here is to give seniors security so they don't have to wake up in the morning wondering whether they can get to the care that they needed and that will help them preserve long and fruitful lives.
Do you think seniors could take a $6,000 or $7,000 voucher out at age 75 and get a health care plan?
Not a senior whose actuarial risks are $11,000 or $12,000 or worse if they get something, a worse disease than that. It's putting them at risk. We're partners with the seniors in Medicare. We've got their backs. I wake up every day thinking about how to help these beneficiaries make sure they can get the care they want and they need. I think that's an important role to fill. And my colleagues in CMS have the same commitment. Sending them out on their own to go navigate this very difficult system, which isn't always friendly to their needs, is not the right answer. And taking the law down strikes me as a terrible answer. It means taking away the wellness visits we've just added, removing access, first dollar access to preventive coverage. It means putting the people on the donut hole back at risk now, so that the lady I met in Atlanta who can't afford her medications right now is going to have her blood pressure rise and get a stroke as a result of that. It means, by the way, that we decrease our focus on quality, because this law has in it unparalleled tools for transparency and improvement of care through measurement, support to quality, rewarding quality. In this bill, we now can reward hospitals for making their care safer. We couldn't do that before. Because of this bill, we can reward Medicare Advantage plans that reach 3 or 4 or 5-star levels with more and more reward. That's going to focus the whole industry on doing better for the Medicare beneficiary. When the bill goes away, that goes away. This bill gives us tools to fight fraud and abuse at a level never before. Do we want to let the criminals get away now, just get them out scot-free by taking the law away? It makes no sense to me. The bill is invested in transparency. Beneficiaries and the public at large and providers can find out much more because of this bill about their own performance.
Do you think that if seniors understood what a voucher plan really meant, they would be in favor of, as opposed to the Medicare plan that we have and we're trying to amend and make better?
I don't think I know. I've been out talking to seniors, and when I go to senior centers and I explain this bill, I tell them where we are, they applaud. They want this. They understand how this bill works in their interests, and how when I go to work every morning, I've got their interests in mind. A voucher system says, go out on your own, God bless you, hope you do okay.
Can I clarify one other thing?
The gentleman's time has expired. I do think it's important to note for the record that the Republican plan on health care that was introduced in the Congress was the only plan that was scored by the Congressional Budget Office that reduced premiums across the board, did not cut Medicare, and did not increase taxes. And with that, I'd recognize the gentleman from Louisiana.
Mr. Chairman,
5 minutes.
I hope, Mr. Chairman, that if we're going to be allowed to comment in between, outside of regular order, we'll...
When you're the chair, you'll be allowed to comment.
Okay, well,
Mr. Bustani is
we'll
recognized.
ask for a regular order as often as we
Thank
can.
you,
Dr.
Mr.
Bustani
Chairman.
has the time.
Mr. Chairman, thank you for holding this hearing. Dr. Berwick, I too come from a family line of physicians. I'm a cardiac surgeon.
Yes.
And know of the importance of the doctor-patient relationship, as you do. How do you reconcile your views on provider oversupply? You've made multiple statements with regard to oversupply in markets and so forth. With your actuaries' concerns about shortages, which are real, and the prospect of those shortages getting worse with the current reimbursement rates that inevitably will be cut. I mean, we are seeing reimbursement pressures on physician practices. We already have shortages. Would you agree that we have a shortage in primary care physicians in this country?
We have a shortage of primary care in this country, yes.
Physicians?
Physicians and nurses, yes.
Right. Do you agree that we have a shortage of general surgeons in this country?
In some areas, we do, sir.
What about rural areas?
Some rural areas are having trouble with access to general surgery. I know that.
I think it's more widespread than you seem to be suggesting, sir. But how do you reconcile your view of this? Because your statements seem contrary to what your actuaries are saying.
Sir, please explain to me what contradiction you see. I'll be happy to address it.
Well, the contradiction is that we're going to see shortages.
Yes.
And worsening shortages, which will hurt access to care for seniors, and particularly folks who live in rural communities.
Yeah, well, again, the actuary is making a prediction here. What I see in the Affordable Care Act is an investment in expansion of primary care and primary care services, and I think over time it will have that effect. Investments in health centers, teaching
reclaiming my time, sir, without fixing the reimbursement system, we're going to see more and more physicians either opting out for early retirement. We're seeing fewer people going into medicine.
Yeah.
And how do you reconcile this?
I agree with that. The president has committed to fixing the SGR problem, which we're absolutely committed to working with you and your colleagues on and trying to get past that. That's a serious looming problem in the healthcare system for sure.
Absolutely. And that leads me to my next question, because you've talked often about rewarding quality versus quantity. And yet, in your testimony, I see nothing but platitudes and nothing specific to suggest the path you're going to take on this. And I suggest that there's going to be a lot of work that this committee is going to have to do to dig down, working with you on this issue.
I'll be happy to work with you, sir. Within the work outlined for us in the Affordable Care Act and other legislation, there are very specific ways in which quality will be linked to payment: hospital-based, value-based purchasing, physician.
But we've seen no specifics. Those are platitudes. I understand what needs to be done, in terms of quality. I've done that in hospitals. I took a community hospital from being sort of average to a top 100 hospital in cardiac surgery. I understand those things. But we have to get beyond the platitudes on changing this reimbursement system, because it's at the heart of access problems for seniors and particularly for rural families, because we are going to see access problems. This reimbursement issue is causing physician shortages.
Sure. Congressman, I assure you the specifics are there, they're out there, and I'd be happy to work with you at any point afterward to explain what those specifics are, and I welcome your comments and improvements in those specifics.
Thank you. Now, with regard to technology, you've made a number of statements that seem to be of concern to me, obviously, about downplaying the importance of new technology and innovation in healthcare. We have an innovation tax in this bill that's going to hurt innovation, I believe, in the long run. But you've made statements, I'll quote one. One of the drivers of low value in healthcare today is the continuous entrance of new technologies, devices, and drugs that add no value to care. Can you explain that?
Of course, yes. Some new devices, drugs, are miracles. They save lives and they add tremendous value to care. Others do not. And
so who should decide?
Smarter as a nation.
Who should decide?
Professions, the scientific community.
So when you suggest that there should be a national policy, who's going to make those decisions?
A national policy?
National policy, that's what I'm referring to. You refer to national policy. In fact, your quote is, if we had a strong national policy, it would allow us to know the difference.
Investments and supports to the scientific community to allow us to understand more and more about what works and what works better than other things is very important.
So let me ask you this. Back in the 1950s, when a surgeon saw a patient die from a pulmonary embolus, he put his mind to work on this, and he actually came up with an idea. And working in his garage, he put together the first heart-lung machine. Would that have fit into national policy? What impediments would there have been?
The gentleman's time has expired. If you wanted to respond quickly to that.
I'm very excited by the Innovation Center and what it can offer for exactly people like that all over the country who have a good idea. We now have the ability to help them invest further in that idea and grow it.
But we've seen nothing from that Innovation Center.
The gentleman's time has expired. Mr. Heller is recognized.
Thank you, Mr. Chairman. Dr. Berwick, I appreciate you being here today. And I'm going through some of your quotes, and I know we've heard some of them already today, but frankly, I think they're worth repeating. Quotes like, the NHS is not a national treasure, it's a global treasure. The decision is not whether or not we will ration care, the decision is whether we will ration care with our eyes open. Quotes like, competition in short will hurt you, not help you. Another one, I admit to my devotion to a single-payer mechanism as the only sensible approach to the healthcare finance I can think of. And finally, any healthcare funding plan must redistribute wealth from the richer among us to the poor. Sometimes reading your quotes, Dr. Berwick, I wonder what country we live in. Having said that, I have a significant large district. And as you know, that this health care bill significantly reduces the funding for the Medicare Advantage program. Nearly 1/3 of all Medicare beneficiaries in my district are enrolled in the Medicare Advantage, and that's more than 100,000 seniors in my largely rural district. You just made a comment that you go to these senior centers and you talk to them and they applaud you on what this new program, this new care provides for them. I go to senior centers in my district and try to explain the new healthcare system to them, and I assure you, I don't get a round of applause. You just said that it's a good model. I guess my question is, how you, in your mind, say that this is a good deal for seniors if the net Medicare savings is $575 billion in this piece of legislation, and yet the amount reinvested in the Medicare benefits is $24 billion. If you're going to take $575 billion out of the Medicare system, what benefits do seniors have with only $24 billion put back in?
The projections, as you heard earlier, say that co-payments in Parts A and B are going to go down by $200 a year by the 2019, that fee-for-service premiums will be down by $200, the donut hole will have closed, and seniors will no longer be afraid of losing their drug benefits. Out-of-pocket costs in American healthcare are projected to go down $237 billion. This is a very good deal for seniors and a very good deal for America.
So do you believe protecting the patient-doctor relationship is the goal of this healthcare bill?
Definitely.
Do you believe that patients, their families, their doctors should be the ultimate authority for the individual healthcare decisions?
I believe yes, I do.
Do you believe one of the goals of the healthcare bill is streamlining the system so patients can navigate it more easily?
Yes, I do.
If that is the goal of the healthcare bill, wouldn't a reasonable person think that 100 new boards, agencies, and programs would violate all three of those questions?
I think the health care bill will accomplish all of the goals you just articulated, a smoother, more seamless care. I can name the parts of the bill that will help us do that as a nation in partnership between the public and the private sector. We can see how quality will be improved as a result of this bill, and costs will fall as a result of the improvement of quality. People will be better off because of this bill, I'm sure of it.
Maybe in another country. Thank you. Thank you, Mr. Chairman.
All right, thank you. Mr. Lewis is recognized.
Thank you very much, Doctor, for being here. Thank you for your service. As one member, I must tell you that I love your testimony. Not just like it, but I loved it. And I love your response, your answer to the questions. This is my beginning of my 25th year here. And you've been one of the better witnesses. And I just want to thank you. Thank you and your family for your great service.
I can't help saying, Congressman, what an honor it is to be in the same room as you.
But thank you, sir. Doctor, what would happen to cost sharing for Medicare beneficiary if reform was repealed?
Costs would go up for beneficiaries if reform is repealed, beginning with just with the drug coverage issue. Seniors are very, very dependent on access to medications. It preserves their health and their life and their vitality, and they know it. If this bill is repealed, more and more seniors will lack access to the drugs that they really need. If this bill is repealed, they won't be able to get as easily to the preventive services they need that are going to keep them healthy over time. A little bit less directly, because this bill so much invests in delivery system reform, making care better, smoother. Ask a senior who's seeing 4 or 5 different doctors, taking 3 or 4 medications, what her life is like in a fragmented healthcare system. It's a nightmare. She can't be sure that 2 doctors are prescribing drugs that are not incompatible with each other. She can't be sure that her lab test report will go to the right place. Delivery system reform, improvement of care, is what this is behind this bill. That is where we'll end up, a better care system to be a doctor in, to be a nurse in, to be a patient in. We can make care safer. If this bill goes away, we don't have a plan anymore then for crafting the kind of journeys our patients and our families and our communities really want. Costs will go up, healthcare quality will go down. The bill, it's an open door to the new American healthcare system that we really want and all need and can afford.
Doctor, if the Affordable Care Act was repealed, would those 3 million seniors who receive $250 from the government have to pay that money back?
We're looking at that now. I hope we don't ever have to face that question for real.
Doctor, like Mr. Ranger and others, when I was growing up in rural Alabama as a young child, I never saw a doctor, never went to a doctor. Tell me what is in this bill that will help children growing up, poor people in rural America, black, white, Latinos, Asian American, Native American, are growing up just happen to be poor. Family can afford a doctor. Do you think this is a major step toward providing health care for all of our people, and especially young people?
Yes, high-quality health care, which is what we all want, begins with health care. You have to be able to get to it. And this bill assures the old and the young, in millions of people, that they can get access to the care that then can be made great for them. If they can't get in, they can't get help. This bill goes away. People will wake up in the morning, tens of millions of Americans will wake up in the morning wondering whether they're going to lose their health care coverage or not be able to get it, and that's children and adults. We're talking about a bill that has in it now a guaranteed issue of insurance to children despite pre-existing conditions. That's a major step forward. That means a kid who has asthma, who happens to be in transition, their parents between jobs, cannot be denied access to health care insurance as a result of this bill. Take that away, and you hurt that child.
Thank you very much, Doctor.
All right, thank you. Mr. Gerlach is recognized.
Thank you, Mr. Chairman. Doctor, thank you for testifying today. To switch gears just a bit, one of the gaping holes, in my opinion, in the health care enactment last year was the lack of medical liability reform legislation.
Yes.
And it was interesting to hear the President in the State of the Union indicate his support for medical liability reform. Do you support medical liability reform legislation?
Yes, I do, Mr. Gerlach.
Do you support a cap on non-economic losses?
I support an exploration now in the country as to what forms of improvement in the medical liability system would actually work to the benefit of patients and the quality of the system. I don't know exactly what those will be, but I think we've got to start in that process.
Okay. Are you aware of the state statutes in California and Texas that do have cap on non-economic losses?
It's not my area of specialty, and it's not CMS's direct area, but yes, I'm aware of them.
Okay. So you're open to federal legislation that would include language that supports caps on non-economic loss?
Sir, I'm not in a position to commit myself right now to what I think about any particular set of solutions, but I think we need to begin the national exploration for solutions. Indeed, we are. The Agency for Healthcare Research and Quality has some demonstration projects underway now, but we need more, and I was happy to see that in the President's language.
Okay, thank you. In your testimony, you have the sentence, CMS has new tools to fight fraud that will return money to the trust funds and the Treasury. What new tools does the agency have to really ferret out the waste, fraud, and abuse that is contained in the system?
Two big kinds of tools. I would call them detection tools, which will allow us to identify patterns of abuse of the public trust and actually criminal behaviors. And working very closely with the Department of Justice and the FBI and others, we are engaging in more and more enforcement with quite a bit of return. I think the return on investment calculation shows something like 6.8 to 1 for the dollars we're putting into that. That's the pay and chase part of enforcement. The other part, very exciting for me, is prevention. Why do these people get into the system in the first place? And so we now have rules out there that will eventually allow us to pre-qualify Medicare providers at different tiers of risk by screening them in advance, in some cases in the riskiest levels, with actual criminal background checks that will keep the criminals out of the system in the first place.
Okay. Last fall, I had a constituent that came to me. He sought medical care for a knee problem. The doctor prescribed a knee brace for him. A knee brace was then provided, and under the reimbursement schedule of Medicare, the provider was provided $686 for a knee brace. My constituent then went online and found online that same knee brace for the cost of $194.
Yeah.
So how is it that Medicare, if you're searching for opportunities to find where the waste is, why is it reimbursing a $194 knee brace for $686?
Congressman, I'd love to look at that, into that particular case with you afterwards, if you're willing to do that with me.
I'll submit all the documentation to you, and I've been corresponding back and forth with your branch on this, but keep getting a bureaucratic answer as to why the schedule is the way it is. And I'd like to have a more specific answer as to why we're paying $686 for a $194 knee brace.
I'm delighted to pursue that with you. I will note that the DME competitive bidding system, I think, will more and more allow us to get much better deals for our beneficiaries and for you, for the Congress as my board. I think that it's really important for us to be acting in a market system on behalf of beneficiaries to find the best deals for them.
Thank you, Doctor. Thank you, Chairman.
Thank you. Dr. Price is recognized.
Thank you, Mr. Chairman. Welcome, Dr. Berwick. I, too, am a third-generation physician. My father, my grandfather were docs, as you are a family of 3 generations of physicians. But I really think you missed your calling. I think you'd made a great lawyer for all of the reasons that we can imagine. The issue here is between Democrats and Republicans isn't whether or not Americans have access to the highest quality of care. The issue is whether or not patients and families are going to be in charge of that care, or government's going to be in charge of that care. And by and large, our friends on the other side of the aisle believe that government can make better decisions about this than people. You, in your answers, have confirmed that you basically believe the same thing as well, that government needs to be in place to be able to make these decisions for people, because clearly they wouldn't be able to make them themselves. So it gets down to who decides. Who's going to decide these fundamental questions about health care? In the sale of this bill, as has been cited, the President said, and many of our friends on the other side said, if you don't worry, if you like the kind of health care coverage that you have, you can keep it. Is that true?
But the President said that?
No. Is it true that if you like what you have, you can keep it?
I don't understand your question, Congressman.
Are there any Americans that have lost coverage that they liked?
There's always turnover in the supply.
That's not the question. The question is, because of this bill, are there Americans that have lost the coverage that they want and, in fact, can't have the coverage that they like?
Dr. Price, my answer is that there is turnover always in what's available to beneficiaries. This bill.
Dr. Berwick, that's not responsive to the question, which is why you've seen the frustration up here.
Yes, I know.
The fact of the matter is that there are millions of Americans who have health care coverage, have had health care coverage, and that coverage is going away because of this law. And that's what they're concerned about. Many of them were out on the lawn of the Capitol over the past 2 years expressing this frustration. Were they wrong?
What I'm hearing from the beneficiaries is that they have more choices, more options. They're able to find the care.
Dr. Berwick, with all due respect, you're hearing from beneficiaries who are selected by individuals to come and give you a story that is not reflective of the real world. The real world is reflected by the individuals right here who are going home and hearing from their constituents, patients that you and I used to care for, that they're no longer able to get the coverage and the treatment that they desire. I want to move to quality. Quality is the pivotal issue in this.
Yes.
And the question is, who's going to decide what quality health care is? Because, as you know, treating thousands of patients, what's right treatment for one patient, even with the same diagnosis, isn't necessarily what's right for another patient, because patients are unique, and it takes those patients and families and doctors together making those decisions. Do you believe that that's the case?
Yes, I do, sir. The importance of addressing the needs of every single individual patient is at the heart of my...
Who ought to make that final decision about what treatment that patient receives?
The doctor and the patient.
Doctor and the patient. If I were to tell you that this law violates that principle and that your agency has the power to negate a decision made by a patient and a doctor, would you agree with me?
No, I would not.
So if we can demonstrate that, in fact, that is the case, then you will be supportive of us changing this law to make it so that doctors and families and patients are, in fact, given the right to make that clinical decision. Is that correct?
Dr. Price, I honor the encounter between the doctor and the patient. I also think this law gives us, as a country, tremendous tools for turning the lights on, understanding the quality of the care it's going. Hospitals.
Dr. Berwick, I'll show you line and verse of this law that I believe removes that. Through the Independent Payment Advisory Board, through the Comparative Effectiveness Research Council. There are many who believe that you support rationing and have said that. Do you support rationing of care?
I abhor rationing. My entire life has been spent fighting rationing. There's no substance whatsoever to the concept that
I appreciate that, because we're going to be able to demonstrate for you how this bill provides for rationing of care in this nation, and I welcome your participation in making certain that that's overturned. In my brief time left, I want to make certain that I get to the physicians who are trying their hardest to take care of patients in this country. Many are concerned about the likelihood that they see coming down the pike, that their licensure will be tied to participation in this plan. Can you state unequivocally that you believe that physicians' licensure in a state to practice medicine ought not be tied to participation in any health care plan?
Dr. Price, I'm not aware of the issue that your question refers to. If you're willing to talk with me afterwards about it, I'd be happy
Do you
to
believe that
understand more
physician
what your concern is.
licensure ought to be tied to physician participation in any plan?
I don't understand your question, sir, and I apologize for that. I'd be happy to talk with you about it afterwards, and you can...
I look forward to that.
explain it
Thank
me.
you.
Thank you, Dr. Price.
The gentleman's time has expired, and I will say that, Doctor, you're able to answer in writing at a later time if you so choose to do that. Mr. Neal is recognized for 5 minutes.
Thank you very much, Mr. Chairman. Dr. Berwick, first of all, a word of thanks. Your medical DNA is in Massachusetts.
It is.
What arguably is the mecca of healthcare delivery in the country. I think that any state would be envious of the first-class hospitals that we have, including the teaching hospitals, which is evenly distributed across the entire Commonwealth. The law that is under assault here this morning has high customer satisfaction across the state. North of 77 or 78% of the people are satisfied with the delivery that they've witnessed. Now, the term actuary has been thrown around here frequently. Could you succinctly tell us what an actuary does, Doctor?
I regard our actuary as a kind of consultant. He looks at the financial situation of the agency and of the trust funds, and he advises us on what he thinks about them and their future.
Thank you. And let me bring you to the next point. At Rotary clubs and Chamber of Commerce get-togethers and neighborhood events, our friends on the other side are going to be routinely asked, do you favor a ban on pre-existing condition? And I can tell you the chorus from them is going to be yes. Do you favor a cap on out-of-pocket expense? Yes. Do you favor keeping children on their parents' health care until they're 20? The answer is going to be yes. Do you offer and support more preventive care? Yes. How about more women's health care? Yes. Do you favor, based upon the actuarial references they've made today, getting there through the mandate, which the insurance industry would say it's the only way that it can be done? How might you respond to that?
Well, I agree with all of the above. Not having pre-existing conditions keep you from getting insurance seems to be only logical. Why would we have a system in which if you need the care, you cannot get the care? That makes no sense at all. So if we want a system in which people can be guaranteed they can get care even if they need it, which is the idea behind this law, you have to have an individual mandate of some form. Otherwise, the whole thing unravels, because then people who don't need insurance won't buy it till they do
Until
need
they get
it,
sick.
and the whole actuarial calculation falls apart. It's simply logic. It's mathematically true. I didn't.
Something that an actuary might assert?
Absolutely.
Okay. Dr. Berwick, would you talk a little bit, just the closing minutes that I have to give you kind of a forum here, would you talk about what you intend to do with waste, fraud, and abuse and the cost-saving mechanisms you're putting in place, with Medicare in particular?
Yeah, there's actually two parts to that. I've learned a lot since I've arrived. There's more fraud and abuse than I thought. I now can see the data. I also know that we can root it out and find it, and with the tools given us in the Affordable Care Act now and the support of Congress, we will stop the criminals and we'll stop the abuse and we'll stop the waste. We're diligent about that. My deputy, Peter Budetti, is doing a great job, and the administration is fully committed to it, and I now understand how important and possible that is. There is the other area of error, which is not the same as waste, fraud, and abuse. There are honest errors. There are errors that get in because of the billing and coding systems. We have to work on those also. The President has set a goal by 2012 of reducing the Medicare error rate by half. We're on track. We will do that, and that also will help us have a much more better stewardship of the public trust in support of a better healthcare system.
So that number that we've seen of $50 billion annually could be attributed to fraud. Is that an accurate number in your estimate?
It's sometimes misinterpreted to be the number that applies to Medicare. That's not true. That number is a rough estimate of fraud and abuse costs for the American healthcare system as a whole, which of course affects the private payers and providers as well as the public side of payment. But that's a large number, and it seems to be there.
Thank you very much, Doctor.
Thank you. Mr. Buchanan is recognized.
Yeah, thank you, Mr. Chairman, for the opportunity for this hearing today. It's very important. Dr. Berwick, I represent a part of Florida. We have probably more seniors than any other district in the country. We have 155,000 that are on Medicare. I do a lot of town halls. I've got one this Saturday. And what comes up with a lot of them is the whole thing on Medicare Advantage. We have 30,000 that have been on Medicare Advantage. I don't know what that number is today. But the general perception in all these places is that they're going to lose their Medicare Advantage, and you're saying yet that it's ticking up. I don't see it. I don't hear it. And it's just it's something you got to deal with. You got a heck of a PR problem if you're saying that it's moving the other way.
Congressman, I agree with you. We have a communication problem. I can tell it from the questions I'm getting. People have a lot of misconceptions about Medicare Advantage. It is stronger now than it was before. There are quality measurements now that apply to it. There are bonuses that will be awarded to stronger and more effective Medicare Advantage plans. Enrollment is going up, and I think that the Medicare Advantage plans are seeing the business opportunities and the growth of Medicare
Let me run.
Advantage
I got
over
a couple
time.
other questions I want.
Oh, sure. I'm sorry.
Time's short. So you would disagree with Richard Foster, his assessment that millions of Medicare Advantage recipients will lose their coverage. That was something that he said was quoted.
He's making a prediction, sir, and it's his job. What I can see is the facts on the ground now. He predicted a decrease in Medicare Advantage this year. It's not going down, it's going up. We're seeing decreases in premiums, a healthier system. So he's doing his best at prediction, but I can see the facts, and the facts are that system looks stronger every day, and the plans are behaving as if this is a good area to be in because
Get
they're
me
investing in
get me the facts of how many people have dropped off, how many are adding, because I'd like to see that so I can communicate that back to our district. He also mentioned that 2/3 of hospitals are already losing money under Medicare, in terms of Medicare patients, and the Obamacare is going to make it much worse. They're talking about hospitals having to shut down. What's your response to that?
My response is I meet with the hospital industry all the time now. I regard them as key partners, and we have to be working together. They know and I know that the solution for them and for the rest of, and for Medicare and for the country is better care, to move the forms of care delivery toward higher and higher quality. That reduces costs, it improves care, and it makes them more robust.
Let me
I just got an
mention,
email.
I want to
Can
get
share
one
with
other-
you one other. I got an email yesterday from Denver Health, where they now have documented through improvement of processes in that hospital $100 million of savings while making patients
Let me get to
better
this
off.
last key point, because I wanted to, you call the bill, the law, Affordable Care Act, but let me just mention to you that I met with a large company in our area, one of the largest employer. His health care went up, cost this year, with the same employees went up $1.5 million. Another pharmacist, we went there to talk about issues for small pharmacists, and then he hands me on the way and it says, Congressman, I just got my bill, it went up 22%. I was chairman of the Florida Chamber and chairman of our local chambers. I can tell you with small businesses throughout Florida, throughout our region, it's going up 20% a year. They're saying, what is this health care bill going to do? They're not seeing, I don't know, are you out talking to any people that are in business or create 15, 20 jobs? I mean, everybody's very, very concerned, don't see the savings. It's across the board, substantial increases. How do you respond to that?
All the time I see it, Mr. Buchanan, and that's sort of the point I want to make. It's not the law that's doing that. It's the state of American health care, which is fragmented. It's not paid for correctly. There's a heritage of a system with high levels of lack of coordination, safety problems, infections, injuries to patients.
People see this as just another big entitlement program. They're not seeing where it's really going to, for a family of four, that, in a small business has got to pay half or 25. They're not seeing any reductions. They don't see anything coming down the road. Is this just another big entitlement program? Is that really what we're talking about here?
I would be happy to meet with them, with you, sir, because the answer lies in the Affordable Care Act. Because it is
by the
the
way,
route
I'd
to
love to have
better
you come
care.
down. It's real nice in February in Sarasota. So come on down, meet with our business people, talk to them.
What I explain to them is that their interests and the interests of patients in our nation lie in making better care get better. And then I can show them and would be happy to talk with you about the elements of the bill that allow us to move the country toward better and better care, safer, more reliable, more streamlined.
Let me make one other point. Our cardiologists, I wrote you a letter.
Yes.
They'd love to meet with you. Many of them are concerned about being able to stay in business because of the substantial cuts on Medicare. I'm sure you've got a lot of this feedback. What are you doing about it?
I'm meeting regularly with specialty societies and talking with physicians. They, like I, know that if they can work together with us and with the private sector to make healthcare better, smoother, more streamlined, safer, costs will go down. That makes the system more sustainable, and in the end will be the foundation for their incomes to remain where they want them to be.
All right,
Better
thank
care.
you.
Thank you. The gentleman's time has expired. Mr. Smith is recognized.
Thank you, Mr. Chairman. Thank you, Dr. Berwick, for being here today. I do want to touch on an issue. My concerns are that the complexity of health care is compounded with this new legislation, and therefore making, especially in rural areas, the job of medical professionals even more difficult. The last two annual OPPS rules have included provisions requiring a physician be on-site and available whenever an outpatient procedure is being performed, regardless of its simplicity. I understand CMS takes the position this change is a clarification of existing policy and not a new rule. I also appreciate CMS taking action to suspend its enforcement for the critical access hospitals most impacted by it. However, the fact is the rule wasn't impacting hospitals until it was restated in 2010, and many of the small towns and hospitals affected don't have enough practitioners to meet the letter of this rule. And actually, the people who will suffer are actually, the patients in small communities, hospitals, but certainly the distance between facilities is very great, and this would further compound it. I'll ask in writing for the record questions relating to that, and so we can get some specific responses. But when you look at this new legislation that is now law, I'm concerned that the addition of over 100 new agencies adds to the complexity. Do you see any mechanism in the law that does not actually centralize discretionary authority in these agencies rather than out among the healthcare professionals across our country?
Let me go back to your point about the rural hospitals. I want to say, because they're related, I think it's very important for us to remain mindful of what it's like to give care in every setting around the country and to make that more and more feasible. That is one of the reasons why we delayed implementation of the physician direct supervision rule while we reconsider those requirements for rural and critical access hospitals. We also included rural hospitals under 100 beds, as you know, as well as critical access hospitals. So I'm very sensitive to the issue you're raising. The more general issue of complexity is of serious concern. We need to make sure that every step we take in implementing this law is value added, that it makes things easier for patients and beneficiaries.
I mean, of the over 100 new agencies, do they not have some discretionary authority that did not previously exist?
I'm committed to simplification, sir. What I want to have is, no matter how many agencies are involved, I want to make sure that the beneficiaries' needs are addressed and that the doctors and hospitals that you're concerned about are feeling that when Medicare takes an action, it's something that they understand and that's value added and not just bureaucracy. I'm thoroughly committed to that. You saw the President's executive order just 2 weeks ago talking about simplifications of regulations and procedures. Medicare is going to be very much part of that direction of work.
Well, I just want to bring the message that many healthcare professionals, almost all of them that I talk to, are very nervous about this, about the power of the government increasing in telling them what to do, when to do it, how to do it, not to do it, whatever the case might be. And I just had a very positive experience at my local hospital relating to a family member in the last few months, where I stood amazed at how great our current system is, and certainly I do not want to jeopardize that. And I yield back.
We share that in common, Congressman. Thank you.
All right, Mr. Becerra is recognized.
Thank you, Mr. Chairman. Dr. Berwick, thank you very much for being here and for all your testimony. I wouldn't be surprised if anyone watching this is somewhat confused. A lot of consumers aren't quite sure they are beginning to reap the benefits of, as my colleague Mr. Neal pointed out, that no longer can an insurance company discriminate against them because of a pre-existing condition. All of a sudden they're finding that their recent graduate child from some college who can't yet find a job is still able to stay on the health insurance coverage of that parent. So they're beginning to see the benefits, but I don't doubt that some of them are confused because they hear all these anecdotal stories, or they hear about these projections, or they hear about these scare tactics, death panels, and all the rest. But I think you started off your testimony by saying where we're being told that seniors should be very scared when it comes to HMO Medicare, that they're going to lose their insurance coverage, that it's just the opposite. Can you repeat what the actual numbers show, not the projections or the speculation is?
The projections were of a decrease in enrollment in Medicare Advantage this year. We're seeing a 6% increase in enrollment. There are now 26, on average, 26 Medicare Advantage plans available in every county in this country on the average. We've made those choices more meaningful. A lot of the Me Too plans, the nonsense that was there where there wasn't really any difference, they're gone now. And when a beneficiary looks at their options, they're meaningful options. They can scan down the list of Medicare Advantage and pick and say, that's the one I want. That's the one that meets my needs. Meaningful choices being exercised and lower cost.
And I was about to go there. The other scare tactic is seniors in America, be afraid because your costs are going to rise. And those are the scare tactics and the projections. What's the actual result on paper?
On average, the Medicare Advantage premiums are down 6% this year. Now, that's not for every single person. Some people will choose a Medicare Advantage plans where the premium goes up because they had a different benefit structure that they prefer. But the average premium went down this year, not up.
And let me make sure I understand this. Some 3 million beneficiaries under Medicare, close to 3 million seniors, got a $250 tax-free check to help them pay for their prescription drugs if they fell into this.
Over 3 million if they fell in the donut hole in 2010. This year, if they're in the donut hole, they'll see a 50% reduction in the prices and the cost they're paying for many brand-name drugs.
Well, hopefully we'll be able to continue to have you come and others testify about what actually is in the bill, not what might be or is projected to be in the bill. The other thing I wanted to get into, let me make sure I understand this. You are within the federal government, as I am, as every one of my colleagues is.
Yes.
So you qualify for the Federal Employee Health Benefit Program for your health care.
I do.
And everything that I understand from the bill and having helped push that through and get it enacted and knowing how we're going to try to reduce the cost, one of the things we try to do is give people choices. And as you and I and every one of my colleagues has a choice of plans through the Federal Health Employee Benefit Plan, this new law, historic new law, will give a lot of Americans a choice in what plan they decide to select. Is that correct?
Many choices, more meaningful choices.
And just as members of Congress and you and other members of the federal government receive government support, public support to help pay for the cost of your health care plan, of each and our health care plan, so under this new historic law will Americans get some support, public support, some would say government support, for the cost of or the paying of those health care plans.
That's correct.
Now, some would say that's a government takeover, and I think I did a quick survey. I think that plan, which is now law as a result of the historic passage of health care reform last year, which now gives Americans those same choices through these options, this marketplace and exchange of options that will be available, and with some federal subsidies, taxpayer subsidized assistance, is very similar to what we get, each and every one of the members of this committee get for health care as well. In fact, my recollection is the subsidy that members of Congress, Republican and Democrat, get for their health care under the Federal Employee Health Care Benefit Plan is actually greater than the taxpayer support that will be provided in subsidies for the new law. Is that correct?
I believe so.
So every time we hear folks talk about government takeover of health care, it's interesting. It's not good enough for the American consumer, but it's okay for members of Congress to continue to get government-sponsored health care, and it's okay to have the choices there, but to give that to the American people seems like we're not quite hearing the full story. So I hope we'll have a chance to hear you more often and talk to us more about the implementation of the legislation, and I thank you for your testimony.
Thank you, Congressman.
Thank you. Mr. Schock is recognized.
Thank you, Mr. Chairman. Thank you, Dr. Berwick, for being here. You know, I had a real-life story myself. This week I was back on my district work period, and I had some time with my father, which is sometimes rare. He's a family physician and young man. He's 62, and he informed me that he's calling it quits, much to my surprise. 6 kids in his family, 5 of them are doctors, and not a single one of them is convinced this is going to be good for their profession. And so I guess I challenge you when you suggest that this association or that association or this group or that group supports it. When I go home every weekend, I go home during these district work periods, and I run into doctor after doctor after doctor who tells me this is going to be bad for their profession. So I just put that out there as not some statistical fact, but a reality check, for me at least, in my district and specifically in my family. Would you agree that most Americans get their health insurance from their employer, private health insurance, but those who have private health insurance get it from their employer at this point?
I think it's about 160 million people, yes.
Okay. Is that most Americans who have private health insurance?
It's the majority, I think.
Okay. Are you aware last year when this bill first passed that publicly held companies, specifically, again, coming back home to my home area, Caterpillar Tractor Company, which is in Peoria, other companies like Verizon, John Deere, had to submit to the SEC what one provision would do to their bottom line, specifically the change in Medicare Part D reimbursements. And for Caterpillar, it was a $100 million hit to their bottom line. You're aware of that?
I was not, but please go ahead.
You were not aware of that?
No.
Are you aware that, well, let me back up. Are you aware, your assumption is that the bill as it stands, as it's been passed, will lower health care costs for employers in the long term?
I believe that by improving care in America, which this bill takes a long step toward, care will become more affordable for everybody, not just Medicare, and better.
But specifically, my question is, since most Americans get their health care coverage from their employer, my constituents are specifically interested. Do you believe that the employer's health care that they're paying for will become less expensive?
The route to that goal, which is my goal,
I
is the
share that.
improvement of care.
Absolutely.
And so the improvement of care affects all. If we're not going to make a better American healthcare system, doctors, nurses, hospitals, all of us together, only for Medicare and Medicaid beneficiaries. That would be impossible. So the agenda of making care better, safer, more reliable, smoother, more seamless, that's a benefit to all. And yes, indeed, if successfully executed, and I think that's what our country's headed for now, all together, public and private, it'll benefit the private side as well as the public side of payment.
Well, I find that interesting because I've heard that a lot when I'm in Washington, D.C., but are you aware of any publicly traded company who has to put out for the public their books and for their investors their projections on costs? Any publicly traded company who is predicting their health care costs going down for the next 5 years?
I wouldn't know that, Congressman. What I know is that it's possible to get there, and we ought to be changing that way of thinking over time by making care better. I want to work with the private sector, employers, hospitals, professional societies, those who give care, health plans all together to make care better. Have you ever seen a patient with a postoperative infection that they didn't need to get? Do you understand what that costs in time and morbidity? Well, that could be a private pay patient or a public pay patient. It's still costing money. So I want to change the game in American healthcare with my colleagues in the private sector to make that care safer and better. And when we do that, the care will get more affordable. And I'm not an accountant or a stockbroker, but I'll bet you're going to see companies around this country understand that their health lies in a healthier healthcare system, which is what we're headed for.
Yeah. Again, at the end of the day, I think we're interested in the realities, with all due respect. And the realities are most major companies, and again, I'm not aware of any, you don't seem to be aware of any, major employers who are providing health care coverage is health insurance premiums going down, nor are there predictions that their health care coverage will be going down. I have one final question since my time is about to expire, and it's with regards to, you're aware of the two federal courts that have now ruled the individual mandate portion of the health law unconstitutional.
Two have held one way, two the other.
Okay. I'm curious if the administration is required by the justice system to stop implementing this law, how you plan to comply with that.
You'll have to speak with my colleagues in the Department of Justice and others more qualified than I to answer that question. Right now, my job is to forge ahead and try to make American health care improve, protect the beneficiaries, and implement the provisions of the law unless and until I'm told.
Have there been any discussions in the department
The
relative
gentleman's
to
time
that?
has expired. Mr. Doggett is recognized, and time is very short. We're trying to get everybody in.
Dr. Berwick, thank you for your distinguished service and your candor this morning. We know that an earlier generation of Republicans fought Lyndon Johnson in getting Medicare created in the first place with the same fervor that our Republican colleagues are fighting health insurance reform today. We know that Newt Gingrich was determined to let Medicare wither on the vine and had the support of some of the Republicans who continue to serve on this committee. And now they have laid out a roadmap. You've discussed it with Dr. McDermott, where their ultimate goal is to move seniors to the uncertainty of vouchers, away from the guarantees that Lyndon Johnson signed into law in Medicare, and to shift responsibility to seniors to meet their health care needs, to fend for themselves with private insurance companies to provide for their needs. That's the longer-term goal. But in the short-term goal, it's become increasingly apparent when you cut through all of their repeal rhetoric that what they are really presenting to seniors and individuals with disabilities is a plan to increase the cost of their health care. And I'd like to go through and itemize how this Republican plan will increase the cost of health care for seniors and individuals with disabilities who rely on Medicare. Under existing law that you administer today, if a senior needs a mammogram, colorectal cancer screening, bone mass measurement, will they have to make any copay?
Not as we implement the law.
And so if we repeal that guarantee of no copayment, seniors will have to pay more
Yes, if they
for
want
those
to.
services. Their health care cost under the Republican plan will increase, will they not?
For those services, yes.
Let's discuss the effect of seniors and the increased cost that Republicans want to impose on them right now with the bill that they have already passed with reference to prescription drugs. The estimate, best estimate I've seen through the Assistant Secretary for Planning and Evaluation, and I would ask you about this, is that the average individual who would reach this donut hole gap in coverage, a gap in coverage created by the Republicans with their prescription drug plan a few years back, that when they reach that gap today in 2011, each of those people on average will get a little over $500 in benefits under existing law, total benefits to Medicare beneficiaries of about $2 billion in savings this year under the law. Does that sound about right?
That's correct. And we get to 2019 or
And so what the Republicans are proposing in repealing that law is to hike the cost for prescription drugs to seniors in America this year by over $2 billion, over $500 a piece for those who enter the prescription drug gap. And you discussed this with Mr. Lewis, but do you have a mechanism under their increased health care bill to demand of seniors that they give back the $250 that we gave them through this bill last year for prescription drugs? About 3 million people, you said?
Yes.
Is there any mechanism there?
I hope we don't have
Because
to
I assume under their repeal bill, we're going to be asking seniors not only to pay more this year, but to give back the $250 that they received if they reached that gap last year. Now, what about on the issue of the Part B premium that we ask seniors and individuals with disabilities to pay? Under existing law, according to all the estimates you've seen, won't those premiums be lower than if we adopt the Republican higher senior cost bill? Won't those seniors have to pay more for the Part B premium if Republicans are successful in their attack on Medicare?
Yes, I believe they would.
And with reference to Mr. Camp's assertion that some Part D premiums could go up for seniors, that's true only to the extent that they get more coverage under this bill, isn't it?
Yes, they have a selection.
And any increase is really fairly modest. And finally, with reference to the Medicare argument that our seniors are going to lose the ability to select their own doctor, there are actually incentives under the law that they want to repeal to pay our primary care doctors more under Medicare than they have received at any time in the history of Medicare. Isn't that right?
That is correct.
And that ought to give seniors not only lower health care costs, but more choice than they have ever enjoyed in the history of Medicare. Don't you agree?
I agree.
Thank you so much for your service and for your candid answers. I hope that we can work together to ensure that this Republican plan to eventually privatize Medicare through a voucher system, but in the meantime, this year, to hike costs to every senior and individual with disabilities who relies on the Medicare system, that plan, they can call it repeal, they can call it an attack on President Obama, whatever they want to, but we have to stop this Republican plan to increase seniors' cost. Thank you.
Thank you. Ms. Jenkins is recognized.
Thank you, Mr. Chairman, and thank you, Dr. Berwick, for being here. As you all know, the Independent Payment Advisory Board, the IPAB, created under the new health care law, is charged to determine whether Medicare is spending more than is budgeted, and if so, to offer fixes to cut back on Medicare spending that are then fast-tracked with very little opportunity for congressional input. While I have numerous concerns with this board, including the 15 unelected bureaucrats who will serve on it, and the lack of congressional oversight and approval of their recommendations, I am also concerned as to whether rural issues will be addressed and protected by it. Currently, most hospitals were granted a 10-year exemption from any changes proposed by this board, but critical access hospitals were not included in that exemption. Kansas has one of the largest number of critical access hospitals in the country, and any further cuts or payments could determine whether they keep their doors open. Can you please just speak to us on this issue and further challenges that rural Medicare patients have accessing care, and whether or not they will be protected by this board?
Well, the board, as you know, does not lie within CMS. It's independent. The president supports the Independent Payment Advisory Board, and I support the administration. With respect to rural health care, my commitment could not be stronger, Congresswoman. I care deeply about that sector. It's crucial to Americans. It's crucial to the health of our system as a whole. Indeed, some of the best care I've ever seen in the country emerges in the rural sectors, and I think that gives us an opportunity to learn from them and spread ideas elsewhere. That's one of the reasons why I did suspend the enforcement of the physician supervision rule in the critical access in rural hospitals that I was asked about before. I want to make sure that we don't do anything that impedes not just good care, but fabulous care in the rural settings. I'm committed to that. The Affordable Care Act gives us a chance to understand more about the costs of the input costs in rural hospitals. We'll be looking carefully at that, but it's a sector I care a lot about. I look forward to working with you to make it a healthier and healthier part of our healthcare system.
Are you willing to work with the administration to give the critical access hospitals the same exemption?
I'm happy to talk with you further about that, Congressman. It's not an issue I know in any detail.
Okay. And then I just wanted to follow up on my colleague from Illinois and his discussion about what the Supreme Court could be asked to do. I visited with many small businesses and large businesses in my district in Kansas, and many of them are investing a tremendous amount of money in implementing a law which one of the cornerstones is the individual mandate. And I'm just curious, do you think it really is in the best interest of the American people for us to continue to implement this law, spending a whole lot of taxpayer dollars before we have a final judgment?
Congressman, I'm not a lawyer. I can't deal with the legal aspects of that. I'll take counsel from the members of the administration that are there to help me understand what to do. I think the Affordable Care Act is good for America, and my job right now is to make sure that that goes as well as it possibly can. That's what I'm committed to do every single day, make care better for our beneficiaries, and I'll continue to do that.
Do you have any idea what the price tag is that business is having to spend that will be lost should the individual mandate be overturned?
Business is a key stakeholder in the American healthcare system, and those costs are not sustainable now. Businessmen can tell you that as well as our beneficiaries can. We have to solve that problem. The Affordable Care Act gives us a chance to build an American healthcare system that will thrive, that is sustainable, that's higher quality and lower cost, and that's where the interests of our public investment in healthcare lies, and that's where the interest of businesses lies, and that's what I'm keeping my eye on right now. Better care for everyone and lower cost through improvement.
So you have no idea how much will be lost in the economy because of businesses?
I have a better idea of what will be lost in our economy if we don't get American health care on the track it ought to be on toward better care through care redesign and better services to patients, safer care, better care.
Do you have any idea what the cost to CMS will be? How much will be spent that will be lost should the individual mandate be found unconstitutional?
I don't have a particular number there, no, Congressman.
No. Okay. How do you suggest that we might recoup any of the loss that you do incur should that happen?
Why don't we address that downstream? I hope this law survives. It's a great law, and I look forward to being able to continue to implement it.
So you don't have any plan to recoup the costs?
I go to work to try to make care better for beneficiaries, Congresswoman. That's my job, and that's what I'm doing right now.
All right. Time has expired. Mr. Thompson's recognized.
Thank you, Mr. Chairman. Dr. Berwick, thank you very much for being here and your excellent testimony. I agree with one of the previous speakers who said anyone watching this is probably wondering what in the world could possibly be going on. And some probably even think it's Democrats versus Republicans, a partisan deal here. So I'd like to just add in a couple of comments that have been that I have been made from advocacy groups for seniors. This committee hearing is on Medicare and the effect on seniors, and the same groups that work hard to make sure seniors have access to good quality health care have spoken out on this. Families USA said Medicare's benefits are improved under the Affordable Care Act. The Center for Medicare Advocacy said Medicare reforms included in the Affordable Care Act do not reduce Medicare's guaranteed benefits. They improve Medicare and help safeguard the Medicare Trust Fund. The Alliance for Retired Americans says that this measure strengthens the Medicare program, provides protections to millions of Americans against insurance company abuses, makes prescription drugs more affordable, and provides prevention and wellness screenings as well, which will enhance the quality of life for our nation's seniors. And the Leadership Council of Aging Organizations said that millions of Americans have already benefited because of this bill, and that the economic and physical health of seniors and their families will continue to benefit as the law is implemented further. Do you agree with that, Dr. Berwick?
I agree with all of those, yes.
Well, let me ask you, and just in my little district in Northern California, what would happen to the 10,300 seniors in my district who hit Part D donut hole if my Republican friends are successful in repealing this health care legislation?
I assume many of them would have to choose between medicines and other things that they want in their lives. I've seen seniors that have to choose between medicines and food. I've met seniors who can't afford the medicine, stop taking it, and face the consequences of doing that, stopping their anticoagulants, stopping their blood pressure medicine, having their diabetes get worse because they can't afford to control it, and they're scared.
And you may have answered this question before. I apologize. I had competing hearings this morning. But those same seniors, what would happen with the $250 check that they receive to help pay for their medicines during the time they're in the donut hole? Would they have to send that $250 back?
I believe we're looking at that issue right now just to make sure we understand what would have to happen and do not have an answer yet. I fear that might be the case. I don't even want to think about it if I don't have to.
Mr. Doggett mentioned that primary care doctors get an incentive to be able to provide the health care that we all know has been lacking and help lead to the situation where health care in our country was unsustainable. I think it's also important to note that rural doctors also get an increase in their reimbursement rates. And in my area and in any rural area in the country, this is a huge, huge issue as to how we attract doctors to provide health care for the many, many seniors that live in rural areas. And I just can't emphasize enough how important preventive health care is. Not only is it good for individuals who receive it, but it saves so much money, so many health care dollars when you can detect a problem early on and fix it. What would happen to the 110,000 Medicare beneficiaries in my district who right now today, under the law that we passed, receive free preventive services and free annual wellness exams? Would they lose this under the Republicans' bill?
They'd have higher co-payments if they want it, and some of them would avoid it. And we now know, due to good science and research, that colonoscopy allows detection of colon cancer at early stages. It saves lives. It keeps you from dying of colon cancer because we find the colon cancer earlier. So there are beneficiaries in your district who wouldn't have a colonoscopy because they couldn't afford it. If this law is withdrawn, their cancers will advance, they will die of colon cancer, and their lives would otherwise have been saved.
Thank you. And one final question, Doctor. If our Republican friends are successful in repealing this legislation, in passing their bill, what would happen to the solvency of the Medicare program?
According to the Medicare trustees report from the actuary, the Medicare Trust Fund life is extended from 2017 to 2029, 12 years of extension of the Medicare.
So Medicare would be shortened.
Thank you. The gentleman's time has expired. I appreciate Dr. Berwick for extending in time here. We'll have one more person question. Of course. What we'll do is we'll recess for 5 minutes, and then we'll reconvene for our second panel. So Mr. Paulson is recognized for 5 minutes.
Thank you, Mr. Chairman, and Mr. Berwick. You know, the issue of geographic disparities in Medicare payment is a long-standing problem that has resulted in unfair low payments to healthcare providers in Minnesota and other high-quality, low-cost states. And in fact, well-documented studies show that a variation in Medicare payments are not tied to quality and efficiency. But for example, the Dartmouth Atlas of Healthcare puts Minnesota in the bottom quintile of per enrollee Medicare payments, yet on measures that indicate high quality of care, like avoiding hospitalizations for conditions that can be treated and handled in a different setting that's more appropriate for care for patients with chronic conditions, et cetera, Minnesota ranks really highly. How will this new health care law ensure that the Medicare beneficiaries in my district or in Minnesota, these high-quality, low-cost states, are going to have the same access to care and services as those in other parts of the country?
Congressman, I know this issue very well, and it's a very important one to make sure that payment is fair and adequate, and the geographic variation and costs are well respected in the payment system. Under the Affordable Care Act, there are actually 3 different processes underway right now: an Institute of Medicine study on input costs in for geographic areas that will be due back to us in May or June, and probably in enough time to map that into payment rules for 2012. The Secretary has been required by the law to have a study of geographic variation and costs for hospitals that will be due at the end of the year, also available for use in 2012. And there's a really important longer-term Institute of Medicine study underway now on geographic variation in Medicare as a whole, cost and quality variation. Based on this information, I think we'll be able to craft much more rational regulation and policy to help make sure that payment is fair and equitable and respects the variation in costs and outcomes in different areas.
Well, and Dr. Berger, I think this is essential to actually get to the crux of the problem. This has been an ongoing issue, and my physician community certainly has talked about it for a long period of time. Let me ask this, too. One of the fundamental shortcomings, I believe, of the health care law as well is the failure to recognize that in some states like Minnesota, we have an pretty low uninsured rate and a well-functioning marketplace that costs could rise in the presence of unnecessary and unwarranted regulation from now the federal government. For example, the new state exchanges are likely to require new levels of certification of health plans, essential benefit offerings, and even network adequacy standards. These activities are now currently overseen by our Department of Commerce. Why do we need Washington or the federal government to ensure that Minnesota's Department of Commerce is acting appropriately, right now?
Well, I'd be happy to talk with you afterwards, Congressman, about the various kinds of administrative costs you're talking about. We do, under the law, have the opportunity now to help states set up enrollment systems which are new and crafted for the enrollment processes that appear under the law through exchanges, integrating exchange and Medicaid enrollment, for example. There's a 90-10 federal match for that. 90 cents out of every dollar that states will put into that kind of new administrative process will come from the federal government. So I'd be happy to talk with you further, if you'd like, about the concerns you have about those administrative procedures.
Well, and I actually would be interested in that, because I want to make sure the new law does not provide any additional layers of regulation that would stifle, I guess, innovation and raise costs. And I'll give you another example, too. I mean, I've heard that there's something like 250,000 pages of additional regulations that are going to come out of this law. That's certainly going to be a challenge if it's a heavily bureaucratic load that's put from a top-down perspective down on our providers in an already very tangled and unwieldy behemoth of healthcare legislation or regulation that's out there right now. And I hear that from my providers on a regular basis.
Yes, sir. I'd be concerned as you are. Let me make it clear. My attitude, from my view as administrator, is a partnership with providers and states, and making things harder for them isn't a good idea. I'm interested in my job of making sure the Medicare Trust Fund is protected and the beneficiaries are protected, but I think we can do that in partnership. And if you're concerned about regulatory burden, I am too. We should talk about it.
And thank you, Dr. Brooker. I just want to follow up one more time on this Medicare Advantage issue, because, it has been forecasted that about $200 billion out of the Medicare Advantage program is going to be cut or overhauled, and that's going to be, according to our next witness, Mr. Foster, who's coming forward, about a 50% reduction in enrollment. And when I travel around my district and around Minnesota, it's very clear that seniors enrolled in Medicare Advantage, they're worried about losing benefits or the Medicare Advantage options altogether. And for the past year, the administration has been trying to reassure seniors that nothing's going to change. But I don't believe that's the case. You talked about the 6% rise in Medicare Advantage for 2011. Obviously, a lot of provisions of the law have not been phased in. But let me just ask you this. I am worried we're going to go back to the days when seniors in Minnesota, for instance, don't have the same options as seniors in Miami or in New York City. And I mean, do you agree that Minnesota seniors should have the same Medicare Advantage options as seniors in Miami or New York City or around the country?
I think they should have robust options, as beneficiaries all over the country should, and I think they're getting them with the improvements that we're seeing in the Medicare Advantage system right now. I don't want your seniors to be worried. The Medicare Advantage program is stronger for them. It's more available to them. The choices are more meaningful now, and they need to know that. And yes, I'm committed to their options.
Thank you.
Thank you. The gentleman's time has expired. Thank you, Dr. Berwick, for being here today and for your testimony. Thank you for extending the time before the committee and accommodating as many members as possible. You can see by the member participation that the issues before your department are of great importance to the people we represent and to America's seniors. So thank you for your testimony about the effects and implementation of of this health care law.
Mr. Chairman?
If members would like to, they can submit in writing to you any questions, and you'd be happy to respond. Yes, gentlewoman from Nevada.
Thank you for recognizing me. Do you think in the future we might be able to make this a little more equitable? Perhaps if those on the more expensive seats, sitting in the more expensive seats, had 4 minutes to question, those of us in the cheap seats might have had an opportunity to question the witness, and I was very patient and very anxious to do that.
What we'll do is, on the second panel, is we'll start with where we left off. Dr. Berwick had limited time. Many times our witnesses come without time limit. Dr. Berwick had a time limit, as does happen on occasion.
This has happened a few times, and frankly, it was Mr. Berwick that I wanted a question.
Yes. All right. Thank you. Yes, Doctor.
Mr. Chairman, first I want to thank you for having me here. I enjoyed it, and I really welcome a chance to join you anytime. And with respect to any members that would like to meet with me personally, that's an open door. I'll be happy to do that at any point if that
Maybe
helps.
that's something that can be arranged. Thank you. The committee will stand in recess until 12:30. Okay, the committee will reconvene for our second panel, and I want to welcome Richard S. Foster, the Chief Actuary at the Centers for Medicare and Medicaid Services. Since 1995, Mr. Foster has been Chief Actuary for the Centers for Medicare and Medicaid Services. He is responsible for all actuarial and other financial analyses for the Medicare and Medicaid programs. Previously, he served as Deputy Chief Actuary for the Social Security Administration for 13 years. He is a Fellow of the Society of Actuaries and a member of the American Academy of